Very good morning. This is as a customary, so we'll just do a garlanding for our president. I'll request our secretary, Dr. Debashish Das, to do the honor for our president, please. We need a big round of applause for him. We'll start with our welcome address by our secretary, Dr. Debashish Das.
A very good morning to all of you. Welcome aboard. Basically, what I feel, OSWB is a movement. It's a ride. It's a roller coaster ride. Join the movement, enjoy the ride. Basically, I'd like to highlight why be a member at all. Basically, we will be getting access to the top-notch masterminds in the ophthalmology today, who are basically the thought leaders in the subject, not only at the state level, but also at the national level. The most updated scientific contents are being regularly discussed and analyzed, which is beneficial for everyone concerned. The members are eligible to undertake the observership programs in any institution of your choice of your subspecialty, along with your choice of consultants. We are also negotiating with Wills Eye Hospital in UK and Singapore National Eye Center such that our fellows are getting observerships in those institutions. It might work out by the end of this financial year. The members are eligible to take the leadership development programs which is being organized with the national faculties. You can participate in the competitive paper presentations, poster presentations, e-posters, and the video sessions in these conferences, in our conferences, and the winners are directly admitted into the national conference, All India Ophthalmological Society conferences every year, and all those passage money and the presentations there will be free of cost by the All India Ophthalmological Society. You can participate in the international CME programs of the society. We just completed the Collaborate 2023 in Bangladesh, where 37 of our members participated in this program. The Vietnam trip is being planned in November this year. It is just announced 12th to 18th of November. The Vietnam conference will be there. We are also in negotiation with the Nepal Ophthalmological Society for their annual conference on 12th and 13th of October, which once finalized will be announced soon. The members will get access to the hard copy of the Journal of Ophthalmological Society of West Bengal. This is being prepared now by Medno or Walter Kluers. Actually, Walter Kluers is doing the Indian Journal of Ophthalmology. So you know the standards, and is going to have an RNI number which will enable us to have a peer-reviewed journal very soon. And only members will get privilege of publishing their articles in this journal. Definitely, we do have our Ophthabuzz, the in-house newsletter of OSWB, both in the e-forms and hard copy, whoever wants to access a copy. You will get an access to the membership of the elite photography group of OSWB, which is passionate about photography. There is a niche fine arts group called Canvas, which is doing fine arts and is publishing an e-mag for the members of the drawings. You will get access to the preferred practice patterns being prepared by the society in order to have an access to the participating patterns to be followed by the members. This can be documented as a medical guideline if need be in the court of law. There are various cultural events, like that we are having the ballroom dance classes for our members, and members are free to join the session at any point of time. You can participate in the 4 sports activities, cricket, badminton, football, and the bowling events to be announced soon. Yoga and meditation classes are on the go. We do have our super specialty groups in the various departments like the retinoblastoma, ROP, and oculofacial aesthetics. The members willing can join in any of these groups to enhance their knowledge in the latest state-of-the-art methodologies in vogue today. You can participate in the scientific programs and the district outreach programs being held every month in more than 1 locations. You yourself can organize community ophthalmology eye screening camps with the help of our support system. We do have our own support system, creating the flexes, managing the optometrists, and giving you a support to ever agile support system you have anywhere in West Bengal. So I request all our members to join the movement and enjoy this roller coaster ride. Thank you so much. I'll request each one of you to beget at least one member from your end in OSWB. That will be a big help to OSWB. Thank you so much. With this, I'd like to invite our president for his presidential address for today's program.
I congratulate all the organizers, especially Rupokkanti Bishwas, for organizing this beautiful CME. I welcome all of you over here. Please enjoy the CME, the Retina CME. Thank you.
So very warm welcome to all present here to this OSWB Retina CME. We'll start with our first session today. It's on diagnostics. So we'll have a lot of talks taking you through OCT, then a few of the retinal pathologies, and that will be in a continuum. After the first 4 talks on OCT, we'll have a bit of discussion. Following that, there's a little shift in the order of the program. So we'll have the management of neovascular AMD by Dr. Devmallo after that, followed by FFA and OCTA, and after that, finishing it off with a how to treat DME. So on to the first talk, which is OCT interpretations by Dr. Devmallo. But before that, I would like to invite our chair, that is Dr. KP Ghosh. If you could please take the dais. Thank you, sir. Also, I would like to welcome our panelists. Dr. Shomdal Prasad, not in the house. Okay. Okay. So, we have Dr. Siddhartha Ghosh with us. Sir. Yes, sir. Yeah. Dr. Vipin Rana, please, sir. Dr. Shaptarshi Majumdar. He will be coming later. So we'll have our more panelists joining in later. So we'll just start with our program now. On to you, Dr. Devmallo.
Good morning and welcome to OSWB Retina CME. I'll be talking about interpretation of optical coherence tomography. So as you know, it is a technique of biopsy without surgery. And it is a cross-sectional anatomy of the retina and it gives accurate quantitative measurement. Also, it is useful for defining a disease pattern and helps in staging of the disease. Also, the new quotation markers help us in indicating whether the patient requires a management or not, and also monitoring and prognosticating any response to any intervention. And these are very important points for which OCT is very important in our day-to-day practice. So coming to, before going into any abnormal structure, let us know what is normal in OCT. So this is what we get when we see an OCT, and this is the vitreomacular interface, which is on one side is the internal limiting membrane, the other side is the posterior vitreous. Any abnormality you should look for. Second comes the inner retina. In the inner retina, there are multiple layers. Internal limiting membrane, nerve fiber and the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, the outer plexiform layer, and the outer nuclear layer. But the most important is the outer retina, the 4 hyperreflective bands. These are very important because in many studies it has been seen that any structural damage to that area, especially in the fovea, results in vision loss. So these are the external limiting membrane, the ellipsoid zone, the interdigitation zone, and the RPE-Brooks membrane complex. Coming to the choroid, now this is a new entity when it comes to OCT interpretation, but it is actually old for us. And now with the advent of swept source OCT, you can see much of choroid now. But generally, we get to see a lot of choriocapillaries, but these are very indistinctly seen in the OCT. But we get to see the satellar layer, the smaller vessel layers, and the hallux layer. And if you can see it properly, you can get to see the suprachoroidal space. Coming to fovea, fovea actually has a very large Henle's layer, which is actually axons connecting the photoreceptors to the outer nuclear layer, which is actually on the outer side. And foveal contour is also to be seen. Coming to reflectivity of normal retina. So plexiform layers and external limiting membranes are moderately reflective. Nuclear layers are low reflective. These are normal findings. And RP, ellipsoid zone, interdigitation zone, interlimiting membrane, and RNFL are highly reflective. We should also know the blood supply. The inner retina is supplied by the retinal blood supply. The outer retina is supplied by the choroid blood supply. That makes the outer plexiform layer as the watershed zone. Actually, there is no blood vessel between the outer plexiform layer in the inner border and the ellipsoid zone of the Brooks membrane in the outer border. And this is seen in octa, where you get avascular complex, the third box, where there is no blood vessel. Any blood vessel is a sign of abnormality happening in that area. This is the international nomenclature for normal anatomical landmark seen on SDOCT and is accepted by the international nomenclature for ophthalmologic coherence tomography. You should have that in your OPD room. Now coming to abnormal OCT, we tend to see the VR interface, the neurosensory or the inner retina, the outer retina, the RP and the choroid, foveal contour you need to see, and any abnormal retinal architecture, thickness and reflectivity has to be monitored. So what do you mean by abnormal reflectivity in OCT? So any hard exudates, fibrin, cotonal spot, pigments, microaneurysms, hemorrhages and precipitates are hyperreflective. But any collection of fluid is hyperreflective. Coming to fovea, it can be flattened, it can be totally atrophied as in case of Stargardt's, it can be absent as in case of foveal hypoplasia, it can be pulled up as in case of vitreomacular traction, it can be pushed up by something below like choroidal neovascular membrane. Schisis can happen in the fovea and full thickness macular hole too. Pseudolamellar hole is one entity that you should know. Here what happens is that the retina is pulled together at the fovea and you get to see that there is a hole there, but if you can see clearly, there is no retinal damage per se. So this is pseudolamellar hole, whereas true lamellar hole have inner retinal damage. And in tractional lamellar hole, the border is sharp. In degenerative lamellar hole, the border is blunt. And tractional lamellar hole responds well to treatment, vitreoretinal surgery. Degenerative lamellar hole, we tend not to treat unless absolutely required. Coming to vitreomacular interface, we get to see taut posterior highlight pulling on the retina, and this is known as vitreomacular traction. When the part, not a part of the retina, but the entire retina is pulled up, it is known as tractional retinal detachment. Epiretinal membrane is a common finding in all of our OCTs, and if you see carefully, you get to see small ILM striae initially, which gradually develops into epiretinal membrane. Care should be taken to see all the sections and through wall quadrant and to check out whether there is any early epiretinal membrane, which might come as a surprise later on. Any preretinal hemorrhage will be in front of the retina. So retinal architecture, unless the itself is pathological, will be normal, and that hemorrhage will cast a shadow below. I now invite Dr. Surbhi Chhetri to talk about the vitreomacular interface and foveal pathology and her experience in treating such patients.
So to start today's presentation, I'll be talking about diseases involving the vitreomacular interface and specifically one particular scenario that we all face in our clinical practice. So we've all had one elderly patient that comes, wants better vision, you do a retinal examination, you see an ERM in both the eyes or maybe one of the eyes. Now the question that we are discussing here is, how do we approach this case and how does one normally handle a combined ERM and cataract? Today we will show what happened to our patient who had presented with such a thing in his eye and how we managed it. So the patient came to our center in 2021 with mild blurriness of vision. He is a 68-year-old male. His BCVA was 6/9 N6 in both eyes. He had no systemic comorbidities. He had no significant cataract also, and we planned for an OCT. Now this was the OCT picture in the right eye and the left eye. So if you see closely, the left eye shows you a hyperreflective membrane, suggestive of a discrete irregular hyperreflective line above the inner retinal surface, which is suggestive of an ERM. This was accompanied by the wrinkling of the inner retinal surface, and then there were hyperreflective spaces between the ERM and the internal limiting membrane. You have to note that all the layers of the retina are, though the foveal architecture and the integrity is not maintained, the retinal layers are almost continuous. and there is no irregularity between them. So at this stage, since the patient had good vision and minimal disruption in day-to-day activities, he was a retired man, we decided to observe for now. Then this patient again presented to our center in 2022 with complaints of blurriness of vision. At this stage, his vision was 6/9 and 6, and the left eye vision had dropped to 6/12 and 8, improving to 6/9 with pinhole, and he had significant cataract. Now again, we decided to go ahead with a preoperative OCT. So this is the right eye picture, and this is the left eye picture. More or less, the CMT is maintained and the ERM is stable. With this in mind, we decided to advise for cataract surgery alone at this stage. Patient underwent the surgery. His vision on day 3 improved to 6/9 and 6. Patient was happy. Now at last appointment, patient came to us again, and this time the vision had dropped to 6/18. We repeated the OCT, and here if you see closely, you will find that not only the CMT is increased, but there are now hyporeflective cystic spaces within the inner retinal layers which were not present there before. At this point, because of these new development of cystic spaces, we diagnosed it as a case of pseudophakic CME with a component of ERM. And we started the patient on topical NSAIDs. Just to give you an idea of how it was before, this was the pre-op image. You can clearly see no cystic spaces, and this is the post-op image, where there is onset of new spaces. And some hyperreflectivity at the ellipsoid junction as well. So we gave him a trial of NSAIDs. Patient came back to us 1 month later, and now the vision had improved to 6/7.5 spectacularly. And when we repeated the OCT now, we can clearly see that all the hyporeflective spaces, the cystic spaces have resolved, and the CMT has also decreased. 2 months later, the patient was maintaining vision in the left eye. Now he has a right eye cataract, and he underwent a right eye cataract surgery, but this time under topical NSAID cover because we knew that there is chances of pseudophakic CME. So this is the right eye preoperative. This is the left eye preoperative before the right eye cataract surgery. And the patient gained post-op 4 vision 6/6. He never came back for further evaluation, so we assume he's doing well. So PCME is a known complication of cataract surgery, and it may affect final visual acuity. Incidence of CME after an uncompleted surgery is 1.2, but in those which have an ERM, the incidence is approximately up to 7%. So in the end, in eyes with cataractous lens, it may be difficult to determine how much of the visual acuity loss is secondary to the lenticular opacity. Cataract extraction will permit the determination of how much acuity loss there is, if any, being caused by the ERM. And then the surgeon can decide whether or not to remove the ERM based on its known impact on the patient's visual acuity. As seen in our case, all cases of ERM do not require removal. And if your patient has an ERM before cataract surgery, you have to keep in mind that there might be a component of pseudophakic CME that might develop later. So it's better to counsel accordingly. Thank you.
Thank you, Dr. Surbi. So we'll now go on again to Dr. Debmallo's presentation. And he'll be continuing with the different pathologies that you can see on the OCT.
So thank you, Dr. Surbi, for your nice presentation. So we'll go into inner retina. So inner retina can have acute retinal ischemia as in case of central retinal artery occlusion. The entire inner retina becomes edematous, and it casts a shadow in the outer retina. Outer retina is per se not damaged because it is getting choroidal perfusion. Unless the choroid itself is ischemic, the outer retina will do well. But since the inner retina is damaged, patient will have severe vision loss. And this is a case of chronic inner retinal ischemia where the inner retina actually thins or it dies. The outer retina remains stable. Patient might have field defect there. Cottonwool spot is seen in the optic, in the nerve fiber layer. It's a sign of exoplasmic stasis, which is also a sign of ischemia. And you get to see a lot of these things. Even after injection, patient doesn't gain vision because the inner retina is not properly seen. This is known as disorganized retinal inner layer. Can be seen in treated diabetic, long-standing cystoid macular edema. I give injection, the edema resolves, but the vision doesn't. It's because the entire inner retina is destroyed. Now, as I told you, the inner retina is supplied by blood vessels, so any leakiness of the blood vessel will manifest in that layer only. So you have cystoid macular edema starting there, and gradually it encompasses the entire retina with time. Hard exudates, and there is another component known as hyperreflective foci. So these are actually small hyperreflective dots which are less than 40 micron, and it doesn't cast a shadow, unlike the hard exudate which casts a shadow. And so this is what we get in diabetic retinopathy in chronic cases of central retinal vein occlusion or branch retinal vein occlusion. So this is one area. Whenever you see a normal OCT, abnormal OCT, check out which layer it is getting affected. You can easily see that the inner retina is affected, and the hard exudates are there gradually coalescing together to form a clump, which ultimately might migrate into the fovea. But one thing is that the outer retina is relatively intact. The patient might have good vision. So that is one thing that you should keep in mind. Retinoschisis is another condition where the entire retina is pulled up. It can be seen in myopic retinoschisis. It can happen in optic disc maculopathy. It can happen in juvenile X-linked retinoschisis, and even in chronic CME. These tell patients who have chronic CME with schisis, they have poor vision response because the entire retinal layer is damaged because of the constant damage. This is more of a degenerative process than an active process, which is cystoid macular edema. Coming to sub-ILM bleeding, we have talked about pre-hyaloid hemorrhage, sub-hyaloid hemorrhage, pre-retinal bleeding. This is sub-ILM bleeding. It can be seen in valsalva maculopathy. It can be seen in acute myeloid leukemia. You get to see the ILM is pulled up, pushed up, and in between there is blood. In this case, we generally wait for it some time, but if it doesn't go, we have to do VIT-ILM peeling. If it is larger, we can do laser as well. Intraretinal hemorrhages, as is seen in cases of branch retinal vein occlusion, central retinal vein occlusion, these are in the inner retina. It is not in the ILM level, it is in the inner retina, but it is definitely over the RP. And it also casts a shadow, and you don't get to see the outer retina properly. So you have to check on every section to see if any outer retina is damaged or not. I now invite Dr. Somak to talk about his inner retinal pathology experiences.
Good morning, everyone. Thanks to SWV for giving me opportunity. So the topic is intraretinal lesions. So what is intraretinal lesion or IRL? This is basically lesions that limited within the inner layers of retina. Some are popularly known as biomarkers. This is absolutely based on EDI OCT, and they are of multiple origin, maybe physiological, maybe because of diabetic retinopathy or DME, maybe because of retinal vein occlusion, maybe because of some other reason. They may or may not require treatment and may persist even after treatment. So this is a very classic EDI OCT. The details have been already discussed by Dr. Demallo. The inner layers are basically the inner 5 layers, and the outer layers are known as the outer 5 layers. So let's start with some physiological intraretinal lesion. This is basically a myopic foveoschisis with presence of staphyloma. 3 things are basically there. One is the cystoid changes. Another is the partial thickness macular hole, and there is a diffuse posterior staphyloma. Basically, posterior staphylomas are best diagnosed on OCT. So what is intraretinal lesions in diabetic retinopathy and DME? First one is most important is DRIL. This is disorganized retinal inner layers. The central part is seen. If we see carefully that this uniformly the 10 layers which are totally disrupted into the central part, and this is called disorganized retinal inner layers. These basically represents macular capillary non-perfusion, and of course always have a negative correlation with the visual acuity and visual recovery. Next comes 3 things. One is intraretinal cystoid spaces, another is hard exudate, another is hyperreflective foci. Dr. Demallo has already told about the things. So the intraretinal cystoid spaces are basically a large cyst, which is maybe more than 200 micron. Basically, they causes their underlying photoreceptor damage. There is disruption of ISOS junction of photoreceptors, and they respond well with anti-VEGF. And between hard exudate and hyperreflective foci, basically both are lipoprotein type things. Hard exudate is lipoproteinaceous deposits, whereas hyperreflective foci is lipoproteins. 2 things that Demallo has already shown, that basically hard exudate, they cause some backscattering. and the hyperreflective foci, they don't cause any backscattering. And two things again we have to remember, that hard exudate is basically directly proportionate to the serum lipid level. So that is why the dyslipidemia should be treated, because more lipid level or uncontrolled dyslipidemia means there is more formation of hard exudate. And the hyperreflective focus, these are basically markers of retinal inflammation. For this reason, these two things are basically treatable with steroids. And now coming to the intraretinal lesions in BRVO, this is very common. There is diffuse cystoid spaces which is known as diffuse CME. Now in CRVO, again extensive cystoid spaces or extensive CME. There are some other lesions which is already discussed, like outer retinal tubules, intraretinal hemorrhage, empty neurosensory retina, and macular telangiectasia, and the list is go on. So to conclude, the intraretinal lesions are mostly pathological. They need treatment and follow-up. They are basically prognostic indicators. So we have to look carefully, then decide, and then treat. Thank you.
Thank you, Somak. And I'll be talking about outer retina as well as the choroid. So outer retina involves neurosensory detachment. It's one of the most common findings we see in our OPD. This is a case of central serous retinopathy, or there is a branch retinal vein occlusion. You get to see the interretinal lighting lifted up along with the inner retinal damage in the left side of the picture. You also get to see a lot of drusen. It can be large drusen, it can be the cuticular drusen, which is short-toothed and it is at the RP level, and the reticular pseudodrusen, which is above the RP below the retina. So this is subretinal deposit. And you also get to see drusenoid PD. We get to see the separation between the RP and the Brooks membrane, but it is not entirely clear. So this is a drusenoid PD, which is behind the coalition of the drusen and the small drusen that are there. The other is serous pigment epithelial detachment. So if you can see, there is an RP layer. The bright color line is the RP layer. Any fluid above it is subretinal fluid. Any fluid below is pigment epithelial detachment. It can be serous. It can be fibrovascular, where there is a notch PED, be very, and double layer sign, where the RP and the Brooks membrane is separated. In these cases, we need to be very careful because this can be a polyp, and where it requires treatment. And so this is a fibrovascular PED, so it can be serous PED, it can be fibrovascular PED, or it can be hemorrhagic PED, as is case of a polyp with huge subretinal hemorrhage. You can see the entire retina is normal, but below that, the interspace is filled with dark colored fluid. This is actually hemorrhage, we saw it clinically. Now, you should know about something, type 1 neovascularization, which actually the CNVM occurs under the RP. But you can see the retinal pigment epithelium and the CNVM has occurred below it. There is development of subretinal fluid, intraretinal fluid, and you can also get to see hyperreflective dot echos and hard exudates, which are poor prognostic indicators. Subretinal fluid is the only fluid, in some studies it has told that this is the only fluid actually which is beneficial for the CNVM. Others are not. Any intraretinal fluid, presence of hyperreflective foci, destruction of the ellipsoid zone are poor indicators that the patient will develop poor vision even after the injection, and this is a prognostic indicator actually. Now coming to type 2 macular neovascularization, here the CNV is above the RP. And type 3, which is a RAP lesion, where the lesion is intralesional, you get to see cystoid macular edema with pigment epithelial detachment. If you get to see in acute case a cystoid macular edema with pigment epithelial detachment, to rule out RAP lesion. Now another entity that we generally call is subretinal hyperreflective membrane. It is any hyperreflective membrane below the retina. It can be fibrin, it can be blood, it can be fibrovascular tissue, anything. So this is known as SREM. Outer retinal defect can happen in photic retinopathy, in solar retinopathy, after closure of macular holes where the outer retinal defect might be there, and sometimes after resolution of central serous retinopathy. Here the outer structure is damaged. Patient might have good vision, but he or she might complain of a scotoma. And the RP atrophy, you get to see a lot of this in cases of age-related macular degenerations, where people come with less vision because there is a small island of vision left, in this case at least, because you get to see the outer limiting membrane, the outer retina present at certain point but absent in the other, which facilitates the light penetration much more in those places. And newer terms comes in when it comes to choroid. You get to see Pachy vessels, which are large vessels above which there will be intraretinal changes. You get to see double layered signs, subretinal fluid, serous pigment epithelial detachment, large, thick pachychoroid. Pachy means thick, so you get to see large, thick choroid. And even hyperreflective dots can be present in the choroid itself. These are all biomarkers by which we prognosticate whether the patient will have good vision, and by which we can tell that yes, the patient is going to benefit from injection or something else. So OCT interpretation is what is the scan that we will do and through what position and what to look for, what is abnormal, to look through all the scan section and pictures provided and the scan direction position, and to correlate clinically with other investigation. And we should also check the other eye. Having said that, I will call up my last speaker. We will be talking of the subretinal condition that I have just mentioned.
Hello. A very good morning to everyone. So as nicely presented by Dr. Devmallo, I'll be presenting the routine cases from routine day-to-day practice about the subretinal lesions in OCT. So here's a case of, one can see here the pigment epithelial neurosensory detachment subfoveally. Along with that, there's a pachychoroid, means dilated choroidal vessel. This is the subfoveal choroidal thickness, and it is thickened than the normal age population. So this is a case of CSCR. Here's almost similar case. Along with the neurosensory detachment, here we can see pigment epithelial detachment. Along with that, the underlying dilated choroidal vessel. This is also a case of CSCR. This is to differentiate from the first case. Here we can see the main finding is this is the right eye, and the below picture is the left eye. Bilaterally there are neurosensory detachment, but not to miss for this hyperreflected dots in the retinal layer along with the hyperreflected dots in the choroidal layer also. So these are inflammatory cells. So actually this is not a case of CSCR, this is a case of VKH. One should correlate with the multimodality imaging along with the clinical findings. So not to miss about the inflammatory hyperreflected dots in the choroidal layer also, in the retinal layer also, and sometimes in the vitreous cavity also. So this is a case of VKH. Here again almost similar picture, there is a neurosensory detachment, there is a dilated choroidal vessel. But not to miss, there is a double layer sign. One can see just below the neurosensory detachment, one can see two lines. One, this is the irregular elevated RPE level, and this yellow line suggests this is the Brooks membrane. So there is the gap. So this is called the double layer sign. So one have to think if there is a double layer sign in a case of chronic CSCR, the patient might have developed CNVM here. So one have to look for the OCT angiography and other help of the other tests to look for whether this is a case of pachychoroid neovasculopathy. It's a case sequelae of chronic CSCR. So here the management differs from the CSCR. This is again almost similar picture. This is another case of double layer sign along with the neurosensory detachment. But the difference from the previous case, I forgot to mention, the in between the double layer sign, the area is hyporeflective. But here, in between the double layer sign, the area is hyperreflective. This is the double layer sign, and always look in between the spaces of the double layer sign. This is hyperreflected, mostly suggestive of blood, as we can correlate in the OCT image, this image also. So there is the blood present in between this. So mostly we are dealing with IPCV in this case. We should think about that. Exception is there. Here there is no pachychoroid. Here almost similar case. Here, as Dr. Devmallo already mentioned, is a case of CNVM, where here we can see hyperreflective disruption of the outer retinal layer and the RPE Brooks membrane complex. Along with that, overlying hyperreflective spaces. These are suggestive of subretinal fluid. This is a case of active CNVM, what we can assess from the OCT. And this patient must need intraloading, 3 loading dose of anti-VEGF followed by PRN or treat and extend anti-VEGF injection. This is another case where we can see again hyperreflective subretinal membrane, suggestive of shrimp, as this is also a OCT biomarker. Along with that, some activity overlying the shrimp, there is the subretinal fluid. This is an active case of CNVM. And here we can see, just like the first picture, the pigment epithelial detachment. Not only that, along with that, there's also a double layer sign. So we here are mostly dealing with the polyp case of IPCV. And here in the second picture, we can see the notch PED. This is mostly suggestive of polyp. We can take help of the ICG also. And this is the last case here. Here we can see again the hyperreflective outer retinal disruption, but along with that, there is the retinoschisis and the thin choroid. So we are dealing with the myopic CNVM in this case. Thank you.
So thank you, Dr. Madhurima. And are we done?
So thank you, SWV. We conclude our session today for the OCT. And thank you all for patient listening. I hope we have a lot of questions and which will be answered by the respective people.
Yeah, thank you so much. It was a wonderful flow with all the interpretation and different cases discussed right from the vitreomacular interface to the subretinal space. Any questions, any comments from the panelists, from the chairperson?
Hello. Excellent presentation, excellent conception, clear conception. I should say, I clearly say that I have also been benefited by this presentation. Thank you to all presenters. Thank you to all. Excellent presentation.
So any questions? So one question from my side to Dr. Surabhi. So if you have already seen that you have a subretinal, you have basically a retinal pathology and you're going for a cataract surgery, would you start your NSAIDs pehle se, or would you see how the patient's responding and then think about starting it?
So after we had this experience, any patient with ERM, I would plan to start with topical NSAIDs pre-operatively and continue for some time post-operatively as well. Because in 30% of cases of patients with ERM undergoing cataract surgery, either the ERM will mildly increase or they will develop some form of CM.
So your experience with such cases, Dr. Siddhartha Ghosh?
Yeah, I think that was wonderfully managed, and thanks Debmalo and Rupak for conceiving this wonderful program. The format was really interesting. And as for your questions now, actually, it's wonderfully managed by Survi. But routine cataract cases are generally, we use NSAIDs, it's recommended to start 3 days prior and continue for maybe 3 to 4 weeks, especially these high-risk cases. I think that should be, that should take care of these problems.
So actually routinely we are seeing ERM cases. Cataract surgeons are also referring ERM cases to for a VR backup. So my one suggestion is that in ERM cases we always go for an OCT and look for whether to go for VR surgery or not. Other than this, one small thing is that ERM can be a sign of any other retinal hole or lattices in periphery. So that RP cells can come to the center and it is converted to the fibroepithelial cells and go converted to ERM. So for any ERM cases, we should look for a lattice or hole in the periphery so that we should not miss this and land up with retinal detachment after cataract surgery.
So does it make any difference whether you're using bromfenac or nepafenac or ketorolac-tromethamine? I think Dr. Survi does.
From the studies I read, statistically it makes no difference whether you're using FLIR or you're using bromfenac or you're using Nevanac. or you're using Nebafenac, statistically speaking. But then clinically, I don't know how everyone's experience is. I usually use Nebafenac. I use Nebafenac. But again, in the number of papers I've read, they've said there is no difference.
And
but again, topical Nebafenac has a higher penetration compared to Bromfenacs, and the Bromfenac converts.
We can start 1 week before surgery also.
Yes. One more thing I would like to highlight is, as Somo said, this patient incidentally did have a lattice in the other eye, and along with that there was an ERM, so I think his point is quite valid.
In continuation of Dr. Shomabo, I will, recently I had faced a case. Always try to look for whether it's idiopathic or secondary to some other disease. In some ERM, whether the adhesion is more, we must think the patient might have a secondary BRV or macular BRV like that case. So we directly don't jump to direct surgery. First to look for whether it's idiopathic or secondary to some other causes. We can prognosticate before surgery, any kind of surgery, or cataract or combined surgery.
If you have a similar situation with a macular BRVO like Madhurima just mentioned, would you go for a surgery when it's a grade 3 ERM or maybe grade 4 ERM? Would you go for a surgery? ERM surgery?
You have.
So, before going into any surgery, we tend to see the structural integrity and both the inner and the outer retina, and the damage the ERM is causing. If the ERM is significant, as you said, it is grade 3, grade 4. If the outer retina is intact, yeah, why not go for surgery? But another thing that is medically important is that the patient is most receptive when the patient is going for cataract surgery, because after that he will benefit with vision. But then gradually the ERM will take over and you will have poor prognosis. So it's like, do it together. If it is like very large ERM, but it is focally adherent, not globally adherent, then it is better to do it. But yes, if you feel that the patient will benefit with the cataract surgery only, it's more about intuitions. But yeah, the structural damage, if it is not there, if there's significant ERM, why not? Because that is the only time you get to do it, because next time he expects you to make you better. With cataract, actually, he is better. Now he will become worse with ERM progression.
So what's your take on, like, how long do you...
See, I personally believe that it is a structural damage, because pulling off the retina destroys the food process of the molar, which holds the integrity of the... There are a lot of other theories. Many people do give Ozurdex, many people give Nebafenac, but these are chronic cystic changes, generally doesn't damage the eye much. Even with the resolution of the edema, the vision gain is not that much. And it takes a lot of time to actually go.
One comment. In cases of ERM with lattice, I think we should be cautious while doing laser, because laser itself causes ERM. So it can actually aggravate your ERM. So in non-high risk cases, we should not do laser. Rather, we should wait, because lattice itself is not an indication to do barrage before cataract surgery. Only in high risk cases, we should explain the patient and then do the laser.
And in young patients, if you get to see ERM, always check the pars plana. And combined amount. The OCT is required.
So another small point I'd like to add in Dr. Madhurima's cases. So hyperreflective foci are not only seen in VKH. Hyperreflective foci can also be seen in CSR, especially in the choroid. So the best investigation would still be to get an FFA to rule it out.
Ma'am, a few things which I would like to add is, like in cases of ERM, what I have seen is, if patient is basically complaining of the metamorphopsia, even if the vision is good, so always ask the patient regarding the metamorphopsia, and if he is having that and we operate the ERM, obviously within a week or so he tends to show the improvement and he's a happy patient. And if there is no complaint of ERM, visual acuity is good, I think we can wait. Secondly, regarding the cystic spaces, one thing in the diabetic macular edema, we can have this hyperreflective content within the cystic spaces, and those respond better to the Ozurdex as considered is a sign of inflammation. One thing was the hyperreflective foci. Hyperreflective foci, as was indicated, that these are the lipoproteins, but as per the latest studies now, it is said that these are not the lipoproteins. Earlier they were thought to be these
subclinical this lipoproteins. But now these are thought to be activated macrophages. And there are studies which, in which it has been seen that where there were more hyperreflective foci, aqueous humor was taken from this anterior chamber, and positivity of the cells suggestive of the activated macrophages was present. So they theoretically they also respond better to the Ozurdex. And in cases of the VKH, CSCR and VKH, multifocal CSCR we say, multifocal this subretinal detachments we can see. But along with that in the VKH, there will be cells we all know. The one thing which I would like to add is the bacillary layer detachment. Although it was earlier thought to be very classical of the VKH, but now it has been described in number of other entities like tubercular, chorditic things, and all other entities. And double layer sign, so beautifully described to differentiate between the PCV and the CSCR. In CSCR it will be hypo, and PCV it will be hyper. Thank you.
Thank you for those great points, sir. So I think now we can, with the permission of the chair, just like to change the flow of the program. So we'll have Dr. Devdulal Chakraborty's presentation before we go on to the FFA versus OCTA. So I would like to invite Dr. Devdulal for his talk on neovascular AMD. Now we all have seen a massive shift in the use of from innovator drugs to biosimilars, and I would think all of us do agree that almost 90% of us have shifted to biosimilars mainly for all our patients. So on to you, sir.
So really, I would like to thank everyone here, especially the scientific committee of OSWB for this kind of opportunity here this morning. I'll be speaking on paradigm shift in treatment of neovascular AMD with made in India ranibizumab. The buzzword is made in India, and recently we had our Prime Minister going abroad and getting those deals signed with new jet engines and all. So closer home to retina, this is also something that's important, and a lot of people who have retinal diseases, retinal vascular diseases need anti-VEGF injections, and it is important that we produce them in our own country, and they come at a price that is affordable for the patients. So these are my disclosures. So what has changed for neovascular AMD, or for that matter retinal vascular disease, over the last 25 years is that anti-VEGFs have come into play, unlike previously where we had only laser or maybe hope to for some miracle to wipe out the disease. Anti-VEGF usage has changed the outcomes of neovascular AMD, and probably the game changer has been ranibizumab, with which we have the largest amount of experience. And if you see, be it neovascular AMD, and be it the other diseases, diabetic macular edema, retinal vein occlusions, or even myopic CNVMs, so it has really changed the prognosis, and you can have consistent visual acuity improvement right up to 12 months or maybe a year or more, and maybe even later also, if these patients can have consistent amount of anti-VEGF being given. Unfortunately, neovascular AMD, as we all know, necessitates prolonged treatment with multiple injections, and what is very, very difficult in the Indian context is that these patients have to have multiple number of injections, and therein the cost often becomes a big hindrance. So we were using Avastin or bevacizumab for a long time, but then we had these issues with cluster endophthalmitis and all, which actually created trouble for us, and so we had to think of something else. So biosimilar ranibizumab has the ability to bring down the cost of anti-VEGF therapy significantly and be effective at the same time. So before proceeding, let's look at a case how biosimilar ranibizumab or razumab, as in this case, is effective. So this is a 56-year-old gentleman coming in with a decreased visual acuity of 4 days, vision of 360. And as you can see, there's a submacular hemorrhage here, there's a large PED, and you have hemorrhage here. So we offered him a bouquet choice of ranibizumab, the innovator molecule, as well as biosimilar, aflibercept, and brolucizumab. And the patient was explained that he will need a loading dose of 3 injections, followed by many injections over, God knows till when. And so you have to figure out what will be best in your case, what will be best affordable for you. So patient opted for Razumab, the biosimilar ranibizumab, and which he thought he could sustain. So let us see what transpired. So we gave Razumab injections along with C3F8 basically to drive down the hemorrhage from the macula, and we didn't use TPA, I should mention here in this case, and just at 3 to 4 weeks time the patient, you can see the C3F8 bubble still there, and the macular hemorrhage is kind of shifting, gravitating down towards the inferior part of the macula, and the fovea is opening up. And this is after the second injection. You can see there's a significant reduction in the pigment epithelial detachment. This area looked a little suspicious whether there was a rip or not, but maybe it was a very small rip, and subsequently we didn't really notice much of a difference. So we went ahead with the loading dose, and this is what happened after the loading dose. Significant improvement, vision improving to 6/12 partial. There's still this PED sort of thing here, and as you can see, the altered hemorrhage, the macular hemorrhage is also coming down. So this is after the second injection, and this after the third injection. So significant decrease in the altered hemorrhage also. The fresh or the reddish or blackish looking hemorrhage is already gone. So this time we thought we will push him to 6 weeks. So we pushed him to 6 weeks for the next injection, and he still looked good. Next we pushed him to 8 weeks for this injection, and he still looked good. The vision was persistently around 6/9 partial, and then we pushed him to 10 weeks. So I was feeling little scared, because this was sort of a PCV, and it's very difficult to kind of know when a PCV is going to strike back. So we thought we will continue at this level, 10 weeks, and patient after 1 year, actually last month was 1 year for him. This is how he looks, 6/9 vision. As you can see from the autofluorescence, you can figure out that there was something happening here, but the Optos barely gives you any hints. So this is part of the reason that we've been using Razumab, biosimilar ranibizumab in Disha Eye Hospitals at an increasing level, and the usage, just to kind of give you the pre-COVID figures, we were using anti-VEGF injections. This is not ranibizumab biosimilar only. All anti-VEGF injections were around 18,000 injections in 1920 financial year, and last year it was around 29,000 odd injections. So there's been a jump also, and what's most interesting is that people are beginning to believe in biosimilar ranibizumab, made in India ranibizumabs, and we have 55% of our patients who opt for the Indian biosimilar Razumab in this case. So mostly in Disha we've been using Razumab so far. Is it all anecdotal? Let's talk about scientific evidence. Well, there's plenty now on public in the public domain. So let's talk about some of our publications. The first thing that we think of when using a medication is that let's at least ensure that this is not something harmful for the patient. So Razumab, we've used a lot of them, maybe around 25,000 or more vials have been used in Disha. So we published this a little while back, and this was a study of 9406 Razumab injections performed in 6404 eyes, and this was cutting across like retinal vascular diseases, and we had diseases such as BRVO, CRVO, NAMD, DME, and certain other miscellaneous diseases. And what we noted was that adverse events were noted in 21% of the injections, but 97% of these were non-serious. And our study also showed that adverse events with Razumab were not different than those already described with other anti-VEGF drugs. And very importantly, we didn't really have much of vitritis or IOI per se, and endophthalmitis rate was 0.01%, which is similar to that with other anti-VEGF drugs. So a lower number of IOIs, lower number of endophthalmitis, lower number of vitritis essentially means that this is a drug that is well made and you can kind of bank on it. So in the real world setting, like I mentioned, intravitreal razumab therapy has an acceptable ocular and systemic safety profile in the management of retinal vascular disease. So coming to today's topic, real-world experience in NAMD with razumab. So this is a study basically of 270 eyes, some of which did not meet the criteria for inclusion. So we had 87 eyes in the innovator group and 77 eyes in the biosimilar group. Coming straight to the results, so if you can see like the baseline, I'll just take a few more, 30 seconds more. So basically if you see the visual acuity at baseline, this was pretty much similar between the two groups, and after the loading dose there was significant improvement in both the groups, and this was maintained right up to month 12. Similar was the story with central macular thickness. Similar baseline visual CMT here of around 400 microns, and this really improved following 3 loading doses in both the groups. This is the razumab group, this is the Eccentrix group or the innovator molecule, and you can see this is pretty much similar in both the groups over time. What about fluid characteristics? We talk a lot about fluid, and there was similar improvement in intraretinal fluid and SRF levels in the patients in both groups. Regarding the distribution of number of injections, both groups it was similar, and there was no statistically significant difference between the two groups. What about adverse events? Similar, very similar, and nothing to be alarmed of. So to conclude, intravitreal injections of innovator molecule and razumab, that is the biosimilar made in India, ranibizumab, shows similar efficacy and safety in Indian eyes with neovascular AMD. Thank you so much for your kind attention.
Any comments on, like if the patient can afford, would you start with the innovator and then shift to the biosimilars, or would you just straight away go with biosimilars?
Basically what we do is, most of us, we offer a bouquet choice of the drugs, unless it is something very specific for which you need something else, you have something else in mind. Otherwise it's a bouquet choice for all patients, and it is the patient who is the decider on what he or she can afford. So don't really offer an innovator anymore as an initial line of therapy for any of the cases.
Would you differ, like would you have a different choice in certain cases like one-eyed patient, and where you would like to dictate what kind of drug?
No, as far as razumab is concerned, considering the volume of experience we've had, more than 25,000, 26,000 vials of razumab that we've used, barring the initial period in 2015 where we had 1 or 2 cases of anterior chamber inflammation, we've not had any issues with razumab. So we are comfortable using razumab in one-eyed patients and like any patient for that matter.
Which is made in India.
Sir.
So what about those drugs? How they are working?
Sir,
is it similar to razumab?
Sir, we've done a small trial with another biosimilar that's from Lupin Reni eyes. I've been part of that study, and it's around 50 injections of Reni eyes that we've given to our patients. We found efficacy is good. We haven't had any IOI issues. We've used a little bit of Renizurel from Reliance, which is part of like people who come in with the medicine from the various government agencies which provide Renizurel. We've used a little bit of Osiva. That's very little, maybe around 15-20 injections. So we've not really had any issues with the other. We've used a little bit of Vizumab as well. So but these are very few in numbers, 10, 20, Reni eyes is 50. So that's how things stand, sir, and we really haven't had issues with biosimilar ranibizumab.
I've used over 100 Reni eyes and absolutely perfect efficacy, no reactions, nothing at all. So I can speak confidently about Reni eyes. I have not used the others.
They always, these Reni eye people always cite you as an example.
I've used over 100 and efficacy is perfect.
Price-wise, which one
is? Since you have a huge number, can you give us some idea? Are the adverse reactions more when you shift from the mother molecule to the biosimilars? Do you feel, or have you seen in your results, do you get any kind of reflection that when you shift from the original drug to the biosimilar, the amount of adverse reaction is more compared to if we continue with one molecule all the time?
Not really, sir, because we have a very, very, very low kind of, now it is even less than 0.01, like reactions. If you leave aside a particular drug, which I would not like to name at this point, other than that, one of the newer anti-VEGFs, let's call it that way. Other than that, the rest of the anti-VEGFs that we use 3 among the rest. One is, of course, the innovator molecule. The one is Razumab, biosimilar ranibizumab. We also use aflibercept, and these between these 3, the rate of any kind of IOI is less than 0.01% across the board, sir. Even post-switch or pre-switch, I mean, like as monotherapy. Absolutely. So we checked on this. This is, of course, a 1-year study that we did, and it was similar.
Over a period of 3 years, it would matter the number.
Absolutely, absolutely. So this is something that's important from the patient's perspective.
Thank you for the great discussion. And now we'll move on to a very debatable topic, FFA versus OCTA. So for the FFA, we have Dr. Krishnendu Nandi. He'll be speaking where FFA is necessary. And for the OCTA, we'll be inviting Dr. Vedang Shah. Okay. So on to you, sir.
At the outset, I'd like to thank WSWB, Dr. Rupak sir, to ask me to present this topic. I am getting old probably to have the topic FFA with me, so but nevertheless, I'll try to defend myself why I need to have FFA in my clinic. So all investigation tools are important, very important, because we cannot depend on single investigation tool. Multimodal imaging is more important than any single investigation in our today's scenario. Previously it was different, although. But still the debate continues whether you need FFA or you have only OCTA. So let us trying to say it's OCTA is still it's evolving. Till now it's luxury. If you have money, you should have OCTA. It is mainly diagnostic tool. It's useful for follow-up, but you cannot start treatment or end the treatment only based off OCTA. And a lot of artifacts involving OCTA till now these are not fully corrected. So let us see few case scenarios. There is a case 1. This is a 32-year-old male with a vision 612N6. You can see there is a area of fibrin with the OCT showing there is a subretinal fluid, subfoveal fluid actually, and FFA shows there is a dot leakage which is very difficult to pick up by the OCTA. So we know by seeing clinically and confirming by OCTA, hardly we do FFA here, but if the patient has chronic history, then we need to have FFA in order to do focal laser. This is a publication in survey which shows the comparison between FFA and OCTA to detect the leak in CSCR. So it's very difficult to detect the leak in CSCR. This is one of the cases, but in cases of chronic CSCR, if you want to pick up the PNV, there's a polypoidal neovasculopathy, then you need to have OCTA. There's another case where the patient is having stromal choroiditis, lot of hyporeflective, echo, then it is hyper echoes in FFA. So these are hyper cases only seen in stromal choroiditis, which can only be picked up in doing FFA, not by OCTA. So in uveitic pathology, definitely you need to have FFA and ICG in your clinic in order to see there is a leakage. In cases of media, it is very difficult to perform OCTA. Activity of retinitis choroiditis cannot be picked up by the OCTA, and choroidal granuloma cannot be imaged by OCTA. Another case, there is a case of peripheral vasculitis with lot of neovasculopathy and lot of CNP area is detected by FFA. We can guide the patient for treatment of laser, peripheral laser, where the central fovea is almost normal. The last case, there is a area of capillary hemangioma. Lot of small hemangiomas, very difficult to detect by the OCTA. So FFA can only identify the early tumors, and OCTA here fails to detect the peripheral tumors. Now this is the last case why the multimodal image is more important than on the single investigation. This is a one-eyed patient practically having lot of subretinal hemorrhage here, the OCT doesn't shows much, but there is a high PED, where the FFA also doesn't show much, where the ICG shows there is an area of hotspot, two hotspot. This we are dealing with polyp. In the second case, the case recurrent back with the polyp again in the some other area. So we have to treat. So OCTA cannot replace till now the FFA and multimodal imaging, but still do have huge potential. Then the suggestion is, if you have money, you should have OCTA in your clinic. Thank you for your patience hearing.
So on to you, sir, Vedang sir, with his presentation on Octa.
I think Krishnendu has made my point very easy. He showed examples which I can refute very easily. Thank you OSWB and Rupakanti sir for giving me the opportunity to speak here. It's not about money. I think it's about the experience that I acquired from Arvind, and that is why I've been able to use OCTA so freely. Not only that, but also with technology advancement, we have to advance. And if we don't, then I think it is going to be difficult for all of us. FFA also started that way, and now OCTA will replace FFA, and I'll show you how. So OCTA is non-invasive. Number two, it is the images are captured in 3 dimensions, and there is no need for dye. So it rules out most of the adverse effects that FFA has, and very cleverly Krishnendu has tried to not highlight any of these points, so that makes it very easier for me. So it works on the principle of diffractive particle motion, and sequential B scans are taken, and the image acquisition takes much less time than the FFA. Not only that, the FFA shows only the superficial slabs, while the OCTA shows not only the superficial slab, but also the underlying, the deep plexus, the choroidal plexus, and we can easily make out a lot of other pathologies in the retina. So let me just show you some case examples. This is a case of proliferative diabetic retinopathy. Nowhere can you see a NVE or an NVD here, but if I do an OCT angiography, I can pick out NVE here, which at the vitreoretinal interface. And if I show you the image back, you can see that the image is here, and the same image you see here, it is the NV here, which can be picked up on the OCTA. If you compare the FFA with the OCTA, you see a fuzzy NVD here, and very clearly if you see the vitreoretinal interface here at the disc, you can pick out the NVD. A case of non-proliferative diabetic retinopathy, patient complains of defective vision, OCT appears to be normal in both eyes, but when you do an OCTA, you clearly see the increase in the fovea vascular zone, the increase in the size, and also in the ischemia, and which clearly explains the reduced visual acuity. So in ischemic diabetic retinopathy, no need to subject the patient to FFA. The FFA and the OCTA, more or less similar morphology, not much difference. And I think it is important not to subject the patients unnecessary to long durations of the screen. In patients with diabetic retinopathy, it is said, as Krishnendu mentioned, we cannot pick up leaks, microaneurysms, but we see here the FFA here, the OCTA here, clearly picking out not only the microaneurysms, but also the morphology and the characteristics of the blood vessels easily picked out. It helps us not only with this decision makings, but also gives us the vessel density and the foveal vascular architecture. So this is how it is represented. Moving on to ARMD, in case of ARMD showing just a mild stain here in the FFA, but a clear BVN vascular network picked up on OCT angiography. In case of type 2 also, we can easily locate the characteristics and the morphology of the BVN vascular network on OCTA. This is to show type 3 and how the OCTA has helped us in demonstrating the resolution of the small tuft of vessels that were present and how they have resolved over a period of time. In cases of comparison of OCTA and FFA, this is an FFA and this is an OCTA, and it clearly shows the vascular membrane network not only on the color map but also on the other images. PCV is picked up. Krishnenduda forgot about mentioning about the PCV, but it has been very clearly seen that location of PCV can be picked up if we are patient and if we look for PCV at the peak of the PED or at the edge of the PED. And it has been clearly seen that PCV is highlighted as a hypoflow structure, while the BVN is seen as a hypo or a hyperflow structure surrounded by a halo, as we can see here. In myopic CNVM, it is easier for us to diagnose the CNVM or the network which is present in the retina. In patients with chronic CSCR, definitely it is important to highlight the vascular network, as we can see here, very clearly seen. So the patient needs injection here, and finding a leak or doing a laser won't help. So this is as we go down into the choroidal layer. Branch drain retinal vein occlusion, you can see the montage image. Montage image clearly shows us the vascular ischemia here and the difference in the foveal avascular zone. And not only that, it also helps us to indicate the collaterals which are present here. So a wide field or a montage image reduces my work, no need to subject the patient to FFA. I can clearly identify the huge area of non-ischemia, vascular ischemia in this patient. And I know what the protocol is, I need to subject the patient to laser. Similar, if I compare the FFA to BRVO, to the OCTA, I can see the image and the resolution very similar to FFA. Rather, it gives me an enhanced image and the depth perception of the foveal avascular zone here. In patients with MACTEL, where FFA would probably just give me a leak or sometimes just a stain, I have a patient here who was diagnosed with CNVM, which was present in MACTEL. As the patient complained of metamorphopsia, I was able to pick this up here in the avascular zone. Now coming to the last case, that is the tumor delineation that Krishnenduda mentioned. That FFA would just help me give a fuzzy appearance of the tumor that was mentioned, but an OCTA helps me to delineate and identify the morphology of the RCH. I had this patient just 2 days ago, and this was identified to be a juxtapapillary retinal capillary hemangioma, and on doing an OCTA of the optic disc, I was able to pick out this blood, the capillary hemangioma blood vessel connecting here. So such is the importance of OCTA, and I think not only apart from the retinal conditions, the OCTA also helps me to diagnose neurological conditions, glaucoma, and one of these examples here of Alzheimer's disease, which fruitfully has been published in the articles. So not only OCTA is non-invasive, it is repeatable. There's early detection of vascular pathology. It gives me an insight into not only retinal but also neurological diseases and helps me to assess treatment response. Thank you so much.
Thank you, sir. So, how many of us are convinced that we require an OCTA in our clinics? Yes, sir. Right.
Krishnenduda also has OCTA.
Though it is a debate, but still we need to have OCTA, definitely.
Yeah.
How many FFAs do you get done, Krishnenduda?
We cannot, I'm saying, I'm coming. Problem is we cannot initiate treatment. We can, but sometimes we cannot stop treatment on basis of OCTA. You have seen the CNVM, but you cannot stop giving injection by only seeing OCTA. You have to have structural OCT also. You can see there is a repeated injection, you will regress the size of CNVM in OCTA, but you need to have OCT structural B scan in order to stop the treatment. Even in myopic CNVM also, if you are stopping the treatment, this is very small CNVM component and not much of leakage or exudation in myopic CNVM. You need to have FFA in order to stop your treatment, whether there is leakage present or not. But in spite of saying that, definitely we need OCTA in our clinic to guide some points like PNV, that is a poakicular neovasculopathy, very difficult to pick up by any other investigation other than OCTA. So few cases definitely has importance in picking up, like repeating in DME. Yes, Rupak.
So I think OCTA is mostly a useless tool. I know that is
Don't
so
be so rude.
So when we had spectralis OCTA, we thought ki its field of view is less, artifact is more. That's why it is not picking up. Now we have Cirrus 6000, which gives a 12x12 montage. Vedang has shown excellent cases, but if you do 100 OCTAs, only 1 or 2 will have such excellent cases. There is so much artifacts in OCTA, and again, retreatment is not guided by OCTA. You will do treatment only if there is fluid or no fluid. All these things that loop is open, loop is closed, those are all theoretical. In a busy clinical practice, we can never determine whether a loop is open, loop is closed. Only 1-2 situation, if the patient has a kidney problem, you cannot do a FFA, you want to pick up new vessels, OCTA is very good. Some cases which Madhurima has shown, CSR, there is a doubt of CNVM, OCTA is very good. But other than that, we still do treatment by OCT.
I think one of the factors that was in discussion just 2 days ago or yesterday only, Saurav sir also put down in the group, neurological kidney patients are not subjected to FFA. That is wrong. I think even Saurav sir put that. There are occasions where we can. But coming to your point where you think that OCTA is not required, I think it is not only about one imaging, it is about multiple images and multimodal imaging. That is what we are talking about. Considering a technician doing the same and considering you doing the same, it makes a huge difference. This point has been highlighted previously also. Sitting at the machine and looking and identifying and assessing the pathology is equally important than just sitting with a printout. So I think that it makes a difference there. I think Rupak sir, OCTA is evolving, not only Rupak sir, for everyone. There are a lot of artifacts, motion artifacts which are seen, I agree. But then overall with time, as FFA progressed, evolved, we had ICG, we have OCTA, and I am hoping 5 years down the line we will not have FAF, we will have only OCTAs.
So for now, we all convinced that each has its own place and both of that is required depending upon what pathology you're dealing with. So thank you, sir. Any other question?
Yeah, ma'am, just would like to add, like FFA has its own advantages, yeah, we do agree, and at the same time OCT has its own advantages. So like in cases of the uveitis, I mean, FFA is irreplaceable till now, because most of the diseases most of the pathology is in the periphery. So we have to do the FFA guided laser, we have to do the scattered laser, for which, in all uveitis conditions, vasculitis specifically, it is very, very important. And in diabetic retinopathy also, in PDR, we do say nowadays that we can do FFA guided laser. If it's not, PDR is not, this CNP areas are not 360 degree. So that is also one of the advantages. And in OCT angio, yeah, it has certainly its advantages in number of conditions. And the one condition which I would like to add is that in uveitis, in cases of serpiginous like choroiditis or in cases of the VKH syndrome, 20 to 30% of the patient, they may develop this CNVM. So what we used to do is that if patient complains of the metamorphopsia, so in those cases, if our experience is, you ask the patient for the OCT angio and you see a subclinical kind of this vascular membrane, neovascular membrane, and if you start treating the patient early, so it responds beautifully to those anti-VEGF, and even on the FFA you may not pick it up. So this was my experience with Professor Vishali Gupta for these two conditions, so where we have beautifully used it. Thank you.
We have Dr. Naresh here also. Dr. Naresh, just to get your opinion about FFA versus Octa. Dr. Naresh is from Arvind Madurai.
Even though Vedang is from our center, I slightly differ. Still we have, we use a lot of FFA images actually.
What indication do you feel that the FFA is absolutely necessary in place in
Very common. Very commonly chronic CSR, because we have to identify all the leaks actually before we laser them. But I don't think it can be done by Opta. in many of the inflammatory cases, still we go for what do you call it, FFA.
True, very true. I think, yeah. Shantida.
So, Rupak, the moral of this story is आपका दोनों हाथ में लड्डू होना चाहिए.
Correct.
Okay. So it's now a practical question to all the experts. Since there are so many experts who are doing so many OCTA and FFA and in their day-to-day practice. Just my question is, which machine do you feel gives least amount of artifact, maximum number of information, and the widest field?
For that, you need to wait for another 2 months, because we are coming up with the comparison of, there will be another program by scientific committee. There is the instrumentation program. So we'll have a head-on of what instrument have the advantage. So we will get the fact for that. So we will feature advantage, cost, and technology. So we will come for that.
Okay, so you are not ready to share the preview.
Yeah, you need to wait for that for another 2 months, and you need to come for that program as well. So let it be a secret. So next, yes, we will give it Sneha to moderate.
So up next, we have redefining DME care using an enduring treatment, Dr. Sudipto Das.
Thank you, Sneha. Good morning, and I thank OSWB Scientific Committee for this opportunity. So we'll be redefining the DME care using an enduring treatment. So these are my disclaimers. So DME care, I think from the very beginning, now if we can just highlight in few points, we usually wait and observe in initial cases where you don't have a central involving diabetic macular edema. Systemic control is definitely a paramount importance. Anti-VEGFs comes next. Lasers mostly is being done in non-central involving DME nowadays. These are the steroids. Triamcinolone is not approved for intraocular usage. Dexamethasone implant is. And surgery in very resistant and recalcitrant cases with specific indications. So how many of us choose dexamethasone implant early in DME care? If you can actually have a show of hands of how many of you have actually. So we have very few, but probably we can actually discuss after the presentation that we are not aware of suboptimal treatment with anti-VEGF in everyday clinical practice. Are we concerned of corticosteroids related adverse effects? For rest of you, are you skeptical about long-term exposure to corticosteroids? So these are the guidelines, Retina guidelines, which came in 2018 with the Ursula group, and this was the basic guideline of those that if you have a history of major cardiovascular event, you go on with corticosteroids. If you have a tractional macular edema, depends upon what is the stage, probably anti-VEGF can be avoided in these conditions. Pseudophakic eye is a good option of corticosteroids as well as anti-VEGFs. In phakic eyes also we can actually have anti-VEGF or corticosteroids, but patients not willing to come for monthly injections or monitoring can actually be preferred for corticosteroids. So there's a preferred first line therapy in this article which showed that serous retinal detachment, hyperreflective foci, and many heart exudates or chronic DME are actually indications for applying these implantable corticosteroids. So this was the Delphi-based approach. This Delphi actually is a structured questionnaire for practicing ophthalmology. This was done in Italy, and where they have seen the management of DME with Ozurdex in DME, there was expert recommendation. So what they felt that a viable first-line alternative to anti-VEGFs in case of pseudophakic eyes, difficulty attending frequent appointments, contraindicated to anti-VEGF therapy, or when you can actually prefer to choose a steroid, all eyes except those are contraindicated, and retreatment as and when required. Compared to others, the anti-VEGFs as first line, when to switch for Ozurdex, they have thought that it's better that we complete the loading dose and then inject Ozurdex in case of persistent edema. Whether we can consider it a switch therapy, and eyes with no improvement even after 6 months, we diagnosed to have these patients to have clinically non-response to anti-VEGFs. And in case of PDR, consider adding laser both with Ozurdex as well as anti-VEGF. So this was the summary of that approach, but the recommendation where they have actually suitable patients, pseudophakic eyes, not suitable for anti-VEGF. These were the benefits which was seen by Ozurdex. And in case of switch, they have all have probably given 3 injections, and then when the non-response was diagnosed to have less than 10% reduction in central macular thickness or less than 5 letters improvement, and greater emphasis was given on anatomical as well as functional response. inflammatory scenario, DME with a high inflammatory component, when you have typical OCT biomarkers showing inflammatory parameters, laser photocoagulation in case of phacoemulsification, we have multiple studies on combination of that. And in case of ocular hypertension, we can safely use these intravitreal steroids. Most of the time, sometimes we give some anti-glaucoma medications, but there is very reduced rate of filtration surgery in this group of ocular hypertension without glaucoma. So less than 5 letter of improvement or reduction in CME less than 20% after loading 3 anti-VEGF injections, we can actually plan to switch these patients to intravitreal dexamethasone. The conclusion was that eyes with refractory to anti-VEGF therapy after 3 monthly injections, which were switched to DEX implant, had better visual and anatomical outcomes of 12 months than those we were continued to have anti-VEGF therapy. This was the study. You can see this was with switching to Ozurdex, and this was if we continue with anti-VEGF therapy in this study. So whether it's suitable in naive patients also. So what is the clinical evidence if we start giving Ozurdex from the very beginning? So this was a review article. Real life observational studies were compiled on minimum follow-up of 6 months. So here, if you can see, that anti-VEGF group actually has 5.8 injections, around 62 letters of improvement. 62 letters was average vision, and 4.7 letters of visual gain with anti-VEGF group. The 6,800 patients, and Ozurdex it was 1,703 patients, 1.6 injections, baseline 61, almost comparable, and a significant benefit of vision improvement of 9.6 letters compared to anti-VEGF. So the author's conclusion with this meta-analysis that Ozurdex obtains better visual acuity improvement in real life than in interventional studies, perhaps due to the possibility of retreatment earlier than 6 months, which is usually followed 6 months in studies. The opposite is true for anti-VEGFs because we achieve more letters gained in interventional studies, perhaps due to more frequent injections in those studies. And in observational studies, Ozurdex seems to yield a better visual acuity gain than anti-VEGFs. So this was the analysis part, the treatment naive group as well as the recalcitrant group, both has gained substantial letters with Ozurdex. This was the IR-Grail's DEX study, which also showed, this was the international retina group of real life 24 months multicentric study, which showed substantial anatomical and functional improvement in naive as well as refractory DME at 24 months with a greater benefit seen in naive patients. This was another one study where 84 patients were included, significant improvement anatomical as well as functional in naive as well as refractory group, with better overall results were seen in the treatment naive patients. So this was the clinical improvement in visual acuity in both groups. If you can see the naive group, the red one, and the recalcitrant group, the blue one, and this was the mean change in visual acuity. So the percent of patients who improved more than 4 letters in naive was more compared to the refractory group, as well as the percent of patients who improved more than 10 letters too. So this was the Castro Navarro et al. The 2019 study. The methodology and baseline characteristics actually were to see the types of DME and the response to anti-VEGF. This was the anti-VEGF one. We had mean number of injections of 7 in these patients, the refractory patients. And when Ozurdex injections were actually given in these patients of refractory, the retreatment criteria was more than 250 microns, presence of IRF or SRF, and decrease in visual acuity. This was the result which was seen with the Ozurdex group, where there was significant CMT change was there in patients who had a subretinal fluid, subretinal detachment compared to the other types of diabetic macular edema. So if you can see here, the SRD group actually had a significant anatomical success with Ozurdex. Possible explanations for these include the morphology of this edema, which was greater than the basal CMT, and probably the inflammatory nature of the subretinal detachment. This was the Bivordex study. It was RCT, where there was it was noticed that there was a reduction in macular hard exudates from baseline to 12 months and from baseline to 24 months with intravitreal Ozurdex. So, and this, when we compared with this, these few Ozurdex with aflibercept, functional outcome was better with aflibercept, but it was in phakic eyes. In pseudophakic eye, it was almost the similar, but the DEX injections were low in number in these patients. This was the anatomical outcome, which was superior in the Ozurdex group compared to aflibercept group. And this was the you can see patients in Ozurdex was 28%, which was end of the study compared to 12% in the macular edema group. So the increase in, while we see the pseudophakic group actually evaluated the mean improvement of vision was similar while compared to both Ozurdex as well as aflibercept, but the number of injections was less with Ozurdex compared to aflibercept. In ocular hypertension, I think most of us have probably experienced that 11% patients treated with Dex implant experienced IOP of more than 25, and most of them actually could be treated with topical and anti-glaucoma medications. Topical treatment for glaucoma was 27% was sufficient enough to treat these patients, and even with ranibizumab also we have seen patients to have sustained IOP elevation. So there are a few clinical cases. I'll just go through a few cases. This is a 65-year-old male who had nephropathy, had bilateral PDR, CSME, status post PRP. He had received Avastin 2 times in last 3 months at US, both eye pseudophakic and both eye persistent cystoid macular edema. This was the initial pictures in November 2021 when patient actually had received injection. He was keen to continue anti-VEGF. This was the vision. You can see some amount of edema here. And after that, again, he has completed 3 injections here. This was in Feb when he came back. Vision was 6/18 and 18. You can see a recurrence of edema. Very mild ERM, I think, was there in the right eye. So we opted the patient for aflibercept or Ozurdex in this patient, and patient opted for Ozurdex. This was in March 2022 when you have a significant reduction of this edema. Though there was a mild ERM, it responded well with Ozurdex. And this was in August. We again have a recurrence of fluid, both intraretinal fluid. And then I asked the patient to continue Ozurdex in PRN basis, and asked also explain the patient that he may require VIT surgery if the ERM increases. This was case 2, a 62-year male who had a PDR, PRP, ranibizumab 6 to 7 times, Ozurdex 3 times in the last 3 years. Last Ozurdex was given 6 months back. There was recurrent CME, cataract. Patient actually had a COVID in between, and so left eye was operated for cataract as well as Ozurdex was given. This was in July. Significant edema in both eyes. After in the right eye was given Ozurdex, left eye cataract operated along with Ozurdex, and vision improved significantly, though there was a persistent edema. This was in August 2021. Following up, if you can see all in this we tried, because he already received 7 to 8 Ozurdex in each eye. We tried to give aflibercept in this patient in the right eye, and you can see here there was not much of a difference in these 2 pictures after aflibercept. So he continued left eye Ozurdex in this patient, and then almost like a PRN, but the interval was much less now compared to in the beginning part, and he was receiving, he has developed ERM, mild amount of traction developing, so probably he will need a VIT surgery later, and is not responding that well with Ozurdex now. So I have not given any other injection on this patient. Case 3, a 58-year-old male, he had his ranibizumab 2 times more than 6 months, persistent CME, diabetic foot, and this was in April. So this patient had a intraretinal hard exudates also in the right eye. This patient received both eye Ozurdex, and this was the post-injection, not much of resolution after 4 months. Right eye, we repeated injection. This was after 5 months. The vision improved much more in the right eye. But you can see the intraretinal exudates in this patient was not significantly less, probably because of ill systemic conditions. And it was after 8 months. Left eye, I did laser once. Vision was 6/12. You can see the Ozurdex implant here can be seen over the disc. And this was after a year when he still has a persistent edema. This was last after 15 months. Vision was 6/12 and 10. Left eye also 6/18 and 12. So probably systemic control in these patients are also important rather than only giving injections. So he had received 5 to 6 injection Dex in last 2 years, and whether to continue PRN Ozurdex, but definitely have to accentuate the systemic control. The last patient was, we could think of a treatment, 9th patient this one, because he received in 2018 Avastin as well as macular laser, but he was a kidney transplant patient, awaiting kidney transplant patient, secured CKD, persistent CME, and this was the edema, intraretinal edema, neurosensory detachment. Both eye we gave injection, and this was after 2 months, the second picture, after kidney transplant, and you can see the resolution of the edema after kidney transplant. So this was 6/9/6, much improved right eye. Again, we repeated injection. And this is the last picture of this patient after 1 year of starting therapy before renal transplant, that he actually has almost like a normal OCT in both eyes with 6/9/6 vision. So to summarize, this is the Retina guidelines. What we actually have a current evidence, patient can, in pseudophakic patients or even in phakic patients who have a clear crystalline lens, we can give, can think of these intravitreal steroids. But in patients where there is poor treatment adherence, DME with high suspicion of inflammatory component and OCT biomarkers has been already being discussed and not suitable for anti-VEGF therapy. So Ozurdex treatment has shown to have substantial anatomical and functional improvement in naive as well and anti-VEGF treatment refractory eyes. Therapy reduces the number of visits compared to other therapeutic regimens and facilitates compliance in real-world scenario. Thank you so much for your patient hearing.
Thank you, sir. Any comments, any questions from the audience? Any comments from the panelists?
So, a very nice presentation, sir. I have just a query that, so I think there are two different entities which are connected. One is diabetic retinopathy.
Great pleasure.
Okay. So one is diabetic retinopathy status, one is DME. So DME can be taken care of DEX implant or by anti-VEGF according to the suitable biomarkers present in that case. But what about the diabetic retinopathy status? The VEGF is still there. So the progression of diabetic retinopathy goes after the DEX implant also. So is anti-VEGF necessary or only DEX implant is necessary to take care of the that patient's eye?
So I think very nice question, because even while we treat patients, especially the naive patients, we have a query that whether these patients will do well with Ozurdex. But I think even if the patient, I have not given much in naive patients, but whoever is responding well in Ozurdex, what we can see that the response is really good, especially the neurosensory detachment, the intraretinal fluid. The problem happens that you have a significant recurrence. It comes back to almost like a normal, abnormal picture pre-injection level after 3 to 6 months. So I think that's one thing, but we cannot combine because all the combination studies, even this study with bevacizumab, Ozurdex also have come up with not much of good results. So probably we are not treating patients thinking that it's having only anti-inflammatory marker or VEGF marker. We have to probably treat case to case. We have to see accordingly, seeing the response and then decide. Because combination doesn't help. I think we must have seen all patients with combination therapy.
One question, say in persistent macular edema, resistance, so the VEGF is nil almost or normal. So there the inflammatory part comes into question. So their DEX implant will work better than anti-VEGF because the anti-VEGF is almost normal or in that cases. So their DEX implant will work more better.
But I think most of us probably have experienced recalcitrant DME to be treated by different anti-VEGFs also. So I think there is a second line of therapy. Most of us probably don't give steroids in a recalcitrant DME. So we can see, and Devrulal also can point out that we tried anti-VEGFs also in recalcitrant DME, and few patients have done, even the studies also have shown good results. Okay, so then Devrulal, you want to add anything on this? Why brolucizumab in the study is telling that we have these anti-inflammatory markers, we have these inflammatory pro-markers, so how these patients are benefiting with anti-VEGF in this group of patients?
I think I'll go back to what you mentioned 3 days back, day before yesterday in fact, regarding anti-VEGFs being able to sort of down-regulate the disease process as a whole. So that is something that's there with very interestingly seen with anti-VEGF, and as you mentioned today also that when like the corticosteroid is over, like not there within the eye, then the patient comes back to a situation where it is almost like the baseline. So of course the exudates, hard exudates don't really come back that badly, if I can call it. But the edema definitely comes back, and I think we have a point here But unfortunately, like you mentioned, the anti-VEGF and corticosteroid combination doesn't really add much. But probably I think we need to see it in its entirety. If an anti-VEGF, whatever be the anti-VEGF, over some time can cause regression of the disease process, with or without a steroid, I think the result on the disease process should be the same. So I think this is something that's very interesting, and sometimes we might need to combine based on our clinical judgment, not to reduce the edema per se, but to treat the overall process of the disease. And I think at this point in time, it's very important to again go back to the previous debate on FA versus OCTA. It's very important to do a FA in this kind of a situation where you have persistent recalcitrant CME going, DME going on and on.
So you feel that FA should always be done in a patient when you plan to switch therapy in a recalcitrant DME?
I feel so. Sometimes obviously there are other reasons we can't do, but if we can do, then I think even better, like OCTA is evolving, FA has also evolved, and we have wide field OCTA.
To see the macular vascular status.
Macular vasculature as well as the periphery also. So if need be, some laser, and it's not a one track thought process that one should have, but it is horses for courses, and I think we can save the day for the patient.
So I don't think there are any more questions, and
all the general ophthalmologists cannot do everything for the retina. So let us, some part is preserved for the retinologist. So at least what we understood is FFA and OCTA both are needed, and whatever is there, try to get the best out of it. And otherwise also anti-VEGF and dexamethasone all are effective, but we need to choose in a customized way to the particular patient. So I think this is the information for the general ophthalmologist, and both are well effective. We'll move on to, for the crunch of time, we'll thanks Sneha for moderating the first session very well, and we will move on to our next session. I will request Dr. Rupak Roy to moderate the next session.
Welcome to the next session, that is medical retina case presentations. I request our chairperson Debnath Chattopadhyay, Debnath sir, Dr. Brajendra Kishore Sarkar, Dr. Shambhuddha Ghosh, and panelist Dr. Devashish Das. So Dr. B.K. Sarkar is not well, so he is not able to join us today. Dr. Shugoto Pal, Shugoto is here. Dr. Amitav Kumar is also not well. Dr. S.S. Pal. Dr. Shubhankar Sri Pal. I request Dr. Tushar Sinha sir to join us as a chairperson. Dr. Saurav Sinha sir, can you join as a chairperson and a panelist? Okay. So first we have two keynote address to present. The first keynote address will be recorded one, but it will be by Dr. Rajiv Raman. It is on predictive utility of deep learning in diabetic retinopathy care, translating into clinical practice. So it will be a recorded talk, but Dr. Rajiv Raman will join us to take our questions. The time we load the video, Dr. Rajiv Raman is a senior vitreoretina consultant at Shankar Nethralaya, Chennai. He is a very eminent researcher, and he is one of the lead workers of AI. He is working with Google and a lot of other companies looking into how AI can help in diagnosing and treating diabetic retinopathy and other retinal disorders. So I think we'll start the lecture now, and after that Dr. Rajiv Raman will join us virtually.
A great pleasure to be part of this meeting. I'd like to thank Rupak for giving me this opportunity. Next few minutes I'll be sharing my thoughts on predictive utility of deep learning in diabetic retinopathy care. So diabetic retinopathy is definitely a public health problem in India. We recently did a study called the Smart India study, and these are the findings which was published in Lancet. So diabetic retinopathy is an important problem. We have 3 million people with sight-threatening disease today in India. Now, AI in medicine has really paved its way in multiple tasks. Mainly, we can divide them as classification tasks where it can diagnose a disease or classify a disease, or a prediction task where people use AI to predict the outcome, predict the features which we don't routinely use for detecting that. Now, coming to diabetic retinopathy, so if we look at classification task, it would be very simple: presence or absence of diabetic retinopathy, grading diabetic retinopathy severity scale, or yes, presence or absence of center involving DME. So these are the tasks which are the classification tasks. Basically, by doing that, we can help, AI can help in screening diabetic retinopathy. Now, what do the guidelines tell about screening? So in 2020, American Diabetic Association had included AI in the diabetic retinopathy screening. They went ahead telling that when not to use AI if a person already has known retinopathy and is having any prior treatment for diabetic retinopathy, or if he has visual impairment, in-person screening is more important than doing AI-based screening. Even the All India Ophthalmological Society, along with VRSI, came out with diabetic retinopathy screening guidelines and have included AI, use of AI in diabetic retinopathy screening too. Are these AI algorithms accurate enough? So this was way back in 2016 when we published our first paper on using AI for diabetic retinopathy, and I'm very happy to share that this was just last year as one of the top 10 articles of the decade by JAMA. After that, there have been multiple publications using deep learning or using AI machine learning techniques to diagnose diabetic retinopathy. And one good thing is that accuracies of most of them seem to be reasonably good. So what to look for when we are selecting an algorithm or to be used in our clinical care? Look at how many number of images the training set was, larger the merrier. How was the ground truth ascertained? Because what AI is trained is based on whatever ground truth has been given. It is in the computer jargon, it is told that it's a garbage in and garbage out. That means if the ground truth is wrong, whatever algorithm will predict also would be wrong. There are multiple ways ground truth can be ascertained in diabetic retinopathy: single grader versus multiple grader versus educated truth. So need to look at how robust that method was. Whether the algorithm was trained on a mydriatic or a non-mydriatic image, because many of these, when they are trained, they take a well-dilated, good images, and when we use it in a non-mydriatic, you may never get the performance what you got with the algorithm tells. And whether it was trained on a single image versus multiple image, because basically it depends on how you intend to use that for your screening. If you're planning to use it as a non-mydriatic single photograph and you have an algorithm which is trained on multiple fields, mydriatic image, the performance of that algorithm will never match what the makers of the algorithm tell about. Is the performance dependent on camera? So this was one of the study which we had done in Thailand across multiple cameras, and we found that if the image is gradable, the performance of AI seems to be similar. However, if it's an ungradable image, that depends on the camera type. Now, there are multiple ways we can think of improving the efficiency of these AI algorithms. So this was one of the study which we had done, where we tried to classify a gradability based on a retinal image, whether it is gradable and non-gradable, and it could classify it with a reasonable good accuracy. Now, this means that if we get a non-gradable image, we can give a prompt to the photographer to try to take image again. So one of the the photographer's factor can be taken care if we use these type of algorithms. How we can implement it? There are multiple ways. it can be at a physician clinic who doesn't have any knowledge on diabetic retinopathy, where AI can be used as a completely fully autonomous way. You can upload the image and AI gives a diagnosis for referral. However, we can also use it, especially like anterior segment specialists who are less trained in diagnosing diabetic retinopathy. It can be more of an augmented tool where the image is uploaded, the ophthalmologist grades it, and then the AI grading is also shown so that he can augment his grading. This is how it has been integrated into the EMR of Shankar Netralaya. So once the patient comes, a consent is taken. This is at the optometrist side. And after the consent, the images are taken, they are uploaded. Additional data are also uploaded, like whether it was a dilated image or whether there was presence of cataract. Then he goes to the consultant. So that's a consultant side, and he gets a chance to grade diabetic retinopathy and diabetic macular edema, and then he can see the AI results. And based on that, if he wants to change, he can change the final diagnosis. Is it acceptable to ophthalmologists? And this was about 2 years back. We did this study. It was a global perspective on acceptance of AI. So more than 1,000 ophthalmologists from 70 countries, and people are more than willing to use AI as a clinical assistive tool. And most relevant people felt is in diabetic retinopathy, followed by glaucoma, AMD, and cataract. One good thing is many were confident that their roles will not be replaced. And one of the barrier which people think is the medical liability from the errors. Now coming to the next task. So this was classification, a more easy job, classify disease versus no disease. Can we think of using AI in diabetic retinopathy to predict? And these are certain studies which we had done, which has potential implication to be used as a predictive tool. So can we detect OCT-based DME from a retinal image? This was one of the work which we had done with Google, where typical approaches, if you want to classify DME or not, put the image, develop a deep learning algorithm, which can detect whether there is presence of DME or not based on image. But what we did was we used the retinal image and took the data from the OCT image, labeled it, and started looking at whether it could predict diabetic macular edema, CIDME. Now, for this study, we used definition based on thickness. It was retinal thickening, device and gender specific thresholds in the ETDRS zone 1 or the central subfield thickness, and based on fluid. Presence of any fluid in the zone 1 was called as CIDME. So like this patient has got CIDME 1 because of thickness, because thickness is more than it's 347. And because there is presence of IRF, again, it comes into CIDME. However, this patient, yes, there is thickness because it's more than 300, which is specific for this machine, but no IRF. So still, this was called as diabetic macular edema, CIDME. Another patient where thickness is low, but there is presence of IRF. Again, we classified it as CIDME. And these are the performance based on the Indian data set. You can see the AUC to detect based on thickness and based on IRF is pretty good, about 0.9 or more in any diabetic retinopathy and even the severe stages of retinopathy. There are some examples. So you can see the top image where you have hard exudates. It looks like there is macular edema. And if you look at OCT thing, there is no macular edema. There is no thickness is not more. There is no cystic space. So this image, when it was processed by this AI algorithm, is told that this patient doesn't have CIDME, which is correct. On the contrary, the lower image, if you look at, clinically looks more featureless. You don't see any edema. And OCT definitely has CIDME, and this image was classified as CIDME by the algorithm. Switching gear to the next predictive method, can we predict presence of DR from pupillary dynamics? And this was actually a couple of years back. We had published in scientific reports that there are pupillary abnormalities in diabetic retinopathy, and that is directly related to severity of DR. Uh, this we did it using pupillary graph, pupillary dynamic, which was captured through a fundus camera called as Orion. It was a Nidec fundus camera. And we found that many parameters of this, like after flash, how the pupil constricts, the redilatation, the hip pulse duration, many of these parameters were altered in people with diabetes with various stages of retinopathy. So we thought that can we use this data to develop a AI algorithm which can you put a video and it can say whether a person has DR or not. And this is the performance of the algorithm on the training, testing, and validation set. You see about 0.8 to 0.9 was achieved, which fairly accurate enough to diagnose diabetic retinopathy from a pupillary response. This was another work which we had done with BITS Pilani, where we tried looking at can we make a risk factor engine to predict chances of DR based on a population-based study done across the country. Major epidemiology study, all the studies data were taken, and we developed a machine learning based diagnosis and ranking of risk factors. In this, we used a method called as Shapley values, which people use for gaming, and also used t-test and ranked the risk factors for diabetic retinopathy. And then we used various machine learning models to predict, can we say whether a person has diabetic retinopathy or not. Another predictive task which we can think of in diabetic retinopathy is, can we predict OCT response of treatment? This was one of the review articles before doing this study. We wanted to know what is the current literature, and we used two approaches. One approach was to predict central subfield thickness after anti-VEGF using OCT and patient-related data. And second was a more physiological way. Can we predict DME, the response of DME based on inflammatory markers? So this was the Zeiss works. We used the EMR data, we used the OCT scans, we used the cube data, and tried putting all of them to find whether a person will respond to anti-VEGF or not. So we took data like clinical parameters like near vision, distant vision, previous number of injections, how many days after injection the measurements were done, thickness parameters like the grid subfield thicknesses, subfield volumes, and thickness both. And we use the model to predict how the response would be. The strength of the coefficient, the correlation coefficient, which is the strength of the AI model in predicting post subfield thickness in an unseen data. More the number of injections, the algorithm perform better. The mean absolute error, if it is low, it is better. And here we found the mean absolute error to be 0.2, which is fairly good with more number of injections. We also tried making an algorithm which could detect the response based on inflammatory markers. This was a work which we did with BITS Pilani. And it was a little different approach. We tried looking at, can we use the information from purely inflammatory edema, that is uveitic macular edema. So we used annotations of these inflammatory markers in uveitic macular edema. We made a deep learning algorithm to detect these markers, and then use this algorithm in diabetic macular edema to see whether it can predict the response or not in unseen data of responder and non-responder. So for this study, we had used about 10,000 B scans. We had 4 data sets. We had a uveitic data set, diabetic macular edema, DME, and a responder and a non-responder data set. We looked at all the inflammatory markers, the hyperreflective foci, hard exudates, intraretinal cysts, cystoid macular edema, neurosensory detachment, vitreous hyperreflective spots, and so on. We also graded their severity, and we had a grading platform where 5 optometrists graded, and the majority grade was considered as the final grade. Then we calculated what we call as a biomarker severity score. So the probability these A1, A2, A3, A4 is given by the algorithm. And based on severity, we had the prediction score. And when we did this, multiplied it, we got what is called as a biomarker severity score for each of these biomarker. And then we calculated what is called as a validity score. We averaged the biomarker severity in responder and non-responder and subtracted that. Then we calculated the final inflammatory severity score by multiplying the validity scores with the biomarker severity score, and added these inflammatory scores to come out with a final scoring. And then we had a threshold which could divide the responder and non-responder. This is the performance of algorithm, though not great. We can use an individual B scan or a stack of B scans, but for responder, non-responder, about 0.7, though it was pretty good in identifying the biomarkers. When we used it on on response and non-response and totally unseen, we could get a AUC of 0.8 using one of the machine learning technique. This is a small video which shows how the algorithm works. So you can put a single or a stack of B scan and then run the program. It starts giving all the biomarker severity scores. You can see each of these biomarkers. And finally, at the end, once it completes this, it gives the total inflammatory score and also suggests whether this person will respond or not respond to anti-VEGF injections. So it's just running the various biomarker severity score, and this patient, it showed that there is high inflammation, will be a poor response to anti-VEGF. Another predicting task could be like predicting various other systemic diseases from retinal image. And one of the work we did was with diabetic neuropathy. This was a work with Cambridge consultants. We had earlier shown that there are retinal changes in diabetic neuropathy. These are mainly functional change, though we cannot see any discernible changes in the retina structurally. And we thought, can we use the power of deep learning to detect retinopathy and neuropathy? And this was a blog which was published by Cambridge consultants. So we used in this study the data from SN Dreams, which is a population-based study, and then trained the data, the images using, we divided it into training and testing data set. And this is the neural network. When the model was trained with all the images in the presence of diabetic retinopathy, this is the five-fold cross validation results. So in presence of DR, definitely there was better detection of neuropathy. The performance of the algorithm was good. However, when we trained the images using only diabetic retinopathy images, it didn't fare much better. However, if this algorithm was trained using no diabetic retinopathy, the performance of algorithm was best, nearly approaching 0.9. And in presence of DR, again, it was better detecting diabetic neuropathy. This was published, and so we could, for the first time, demonstrate from that retinal image we can identify neuropathy. Now that means we can do a simultaneous screening for neuropathy and retinopathy, the two important microvascular complications of diabetes. So to conclude, in 2022, AI definitely is into diabetic retinopathy care in multiple ways. In screening, it can be used to detect sight-threatening diabetic retinopathy. It can detect OCT-related CIDME on retinal images. We can classify it as a CIDME or a non-CIDME. There are works which are happening which can predict the treatment response. And using some tools, I have shown only neuropathy, but people are also done work on cardiovascular screening. So along with retinopathy screening, we can also tend to screen, we can use it to screen other microangiopathies as well. I would like to thank my research team for helping me do all this work. I once again thank Rupak for giving me this opportunity to talk in this forum. Thank you very much.
Good morning, sir. I believe you are in a holiday.
Yeah, actually, I am at Indore. Sorry, I could not connect. I wanted to attend this meeting physically, but we had to go for one important task. So I am now out of town. Otherwise, I would have loved to attend the meeting. I've been seeing some of the last sessions. Really great. Any questions? I'll be very happy to answer them.
Yeah, sir, excellent talk. So I know a lot of your work and how you have been doing it. So from a practical point of view, I think you had explored an idea of sort of a retinal kiosk, because the primary role of AI will be to detect diabetic retinopathy in vast number of population, which we don't have enough number of ophthalmologists to screen in our country. So in a way, so we are seeing more and more bad diabetic patients who could have been treated. So I thought you were working on an idea on a retinal kiosk which will be put in commercial centers, which will have cameras, and the AI will detect retinopathy, and then patient will be referred to an ophthalmologist. So what would be the next step in AI in Indian scenario?
See, one of the things, Rupert, which is a limitation for kiosk and any of the model is the camera, because you can never get down the cost of camera because of the optics and the sensors which it has. So it will never be as low. Like I'm looking at a cost which any physician can afford, which is something like a cost of a ECG machine, 20,000, 15, 20,000. You'll never get a camera in that cost. The other biggest challenge is we have so many 105 million people with diabetes. And if we say that each one needs a dilated fundus examination or a photograph yearly once, it's next to impossible. So now what we have been thinking more is towards a pre-screening approach, that probably we need to do some tests before screening, and those who are positive in that, they undergo a retinal photography. Because you cannot afford to have so many cameras to screen everybody. Now, these pre-screening tools could be AI-related risk factor engines. It could be related like the pupillary dynamics. We have worked on cystatin. You were part of it. Serum cystatin work, which we had done. And again, it has been replicated. I'm so happy last month, again, another group have shown that cystatin seems to be an important marker for sight-threatening disease. So probably we will have these blood-based biomarkers which will be initially done, and if they are positive, fundus photography would be the right answer.
Right. So just to expand on the thing that you said, that is pre-screening. So what I understand, what you mean by this is, it is not possible for ophthalmologists to see all the patients with diabetes. And it is also not possible for ophthalmologists or technicians to to take fundus image of all the diabetic patients also, because the burden is huge. So what you have proposed is doing sort of a blood test for patients, and if the blood test results are positive, those patients will undergo photography to look for diabetic retinopathy. And you have also devised a point of care device. So can you just elaborate more on that?
Yeah, so actually we did this study again as a part of Smart India study across many centers. And we first looked into whatever is in the literature. So there are about 16 blood-based biomarkers which people have identified for sight-threatening disease. So we did it on a huge sample, nearly 500 patients from India, 500 from UK. We did all 16 biomarkers, and we found that cystatin C seems to be an important biomarker, blood-based. And very clearly it was different in both India and UK population. But if we add to that risk factors like duration of diabetes, HbA1c, and cystatin C, it becomes a real good marker like the AUCs were 0.9, 0.95. So we could very well detect people like this is a person with sight threatening. Now, if we do that and those who are positive, so if you read the paper which we have published in JAMA Ophthalmology, we did this comparison that suppose I have 1,000 people with diabetes and I need to detect sight-threatening disease, which would come out to be about 5 of them. I need to take 1,000 retinal photographs. Now, if I do this pre-screening approach of risk factor and cystatin, and those who are positive, they undergo a photography, we don't lose much. We may lose 1 or 2 patients, but the number of photographs would reduce to nearly 600. That means 400 we did not do. So that was the whole approach we are suggesting, and more validations are happening. Happy to share that now we'll be doing another all India study with AIOS, because AIOS has taken up that probably this pre-screening approach we should explore more and see how we can do it. And that seems to be a better answer. Camera is chaos. The biggest limitation is the cost. And there are groups who are working now on a low cost sensor, low cost optics of the camera. If that reduces, the cost of camera would dramatically reduce.
Sir, we have 2 questions. One from Dr. Saurav Sinha. Sir, go ahead.
Yeah.
Rajiv, hi, how are you?
Dr. Saurav.
Okay, so I remember a meeting in which Dr. Kim was mentioning about the legal aspect of saving these images, sharing images with other people, and there was a legislation coming in with the government of India. Your take, your understanding in very short, what we as clinicians should do or understand this if patient asks us, or if we are approached by somebody else to do a study, what is it that we should look for?
See, I think the first important thing is let it be a clinician-driven program. Because if it is a technologist-driven study, then the issues come. If it is a clinical-driven problem, you get your ethics, you get all your legal requirements, you get all the things done before you start the process. But yes, that is a worry, as Dr. Kim rightly said. And now legal regulations are being set up even in India. There are task forces which are formed. We don't have real guidelines, but there are now guidelines coming up. Globally, there are pretty good guidelines. So I think if you, the other one thing which I always say that if you, somebody comes to you that I can make a AI algorithm and this is the purpose, you get approval for the intent of use. The problem of technology is that they will use that image for some other purpose. So if you can get a consent and your all agreement should have that it is meant only for diabetic retinopathy. Tomorrow they should not take this image and use it for determining gender or determining anything else. I think that is something you should be very clear.
Right. Thank you so much.
Thank you, sir. We'll take one more question from Dr. Mukesh Jain. I'm happy to see Mukesh as one of your co-authors for that pupil paper. So Mukesh, go ahead.
Excellent talk, as always, Dr. Rajiv. Sir, I wanted to ask you, what is the reason that you have given the clinician, the EMR one from Shankar Netralaya, the chance to re-rectify or re-correct, because it will induce a bias and make the AI more accurate when you are comparing it. Rather, it should be the reverse way.
No, I will tell you the purpose of giving it to the, this is an implementation. This was not a study. So the AI algorithm is already made. Now, how want to use it? One is like, if your physician is using it, it is fully automatic. Anterior segment, I thought that, see, this is the whole purpose of many of the AI algorithms have not come into clinical practices because of the acceptance. Nobody wants to accept that, no, AI is better or I am better, that question comes. So the best way is to help it augment our decision. So what we do is we take the image, let the ophthalmologist see the image, grade it, and he can also see AI grade. And he, if suppose he wrote it as moderate and AI grade has told it is PDR, he can zoom in and see again. And ultimate power is with the physician. He can dismiss the AI diagnosis or he can take it, but it should be more like an assistive tool rather than fully depending on that. That was the whole purpose. So for ophthalmologists, that is the only way the algorithm will get, people will have more acceptance.
Thank you. Thank you, sir. Thanks a lot. For want of time, we'll move on to the next speaker. The next topic is neovascular AMD or PCV. Does it really matter? And it will be, the keynote lecture will be given by Dr. Ajit Madhav Wagle. Welcome, sir. Dr. Ajit Madhav Wagle is currently the medical director and senior consultant at International Eye Cataract Retina Center at Ferrier Park Medical Center and Mount Elizabeth Medical Center in Singapore. He is also a visiting consultant at the Department of Ophthalmology and Visual Sciences, National Healthcare Group, Singapore. Welcome, sir. We are ready for your talk.
So let's move on to this talk and let's go to the topic today we are talking about is neovascular AMD or polypoidal choroidal vasculopathy. Does it really matter? So when we see patients with features of macular degeneration, neovascular macular degeneration, very often this dilemma comes in our mind because treatment for both is, at least in majority of cases, anti-VEGF therapy works very well. And then is there a need to really investigate further? So let's look into this topic further. So this is a patient presenting with submacular hemorrhage and a grayish lesion at the center of the macula. The angiogram shows features of occult CNV on a fluorescein angiogram, and the OCT shows this pigment epithelial detachment with subretinal blood and also some sub-RP blood. So is this neovascular AMD or is this polypoidal choroidal vasculopathy, and does it really matter? Well, what is this condition called as PCV? I think we are quite familiar with it because this condition has been around since Januzzi described it in 1980s. But primarily, this is a disease of the inner choroidal vasculature and is characterized by presence of two particular things: a polyp, which is a polypoidal lesion, vascular lesion, and a vascular network. In addition, there could be subretinal fluid, there could be a pigment epithelial detachment, or sometimes, of course, massive hemorrhage. To differentiate PCV from neovascular AMD, clinically, of course, presence of orange nodular vascular lesions are quite useful. And of course, a relative lack of drusen in the fundus photograph or the fundus exam helps to differentiate it from typical wet AMD. But more importantly, OCT features of polypoidal disease are quite different from typical AMD. So there is a pachychoroid spectrum where the choroid under the macula is congested and thick compared to a thin choroid on the in typical wet AMD. And then you see these sub-RP ring-like lesions. You see sharp, tall, peaked pigment epithelial detachments. And sometimes you see this double layer sign, which is a splitting of the RPE from the Brooks membrane because of the vascular network. So quite recently, a few years ago, the Asia Pacific Ophthalmic Imaging Society PCV work group has found that these three features, the orange vascular lesions, sub-RP ring-like lesions, and tall peaked PDs on OCT, are sensitive enough to suspect PCV on an OCT angiogram in absence of an ICG angiogram, which is actually diagnostic for diagnosing polypoidal disease. So if we look at the composite of these images, we can see here serosanguinous maculopathy and a polyp-like lesion right at the close to the fovea. The angiogram shows a nodular hyperfluorescence, and if we run a scan through this exactly, we see a tall PED with a ring-like lesion here and the double layer sign which is seen around here. So these features are quite typical of polypoidal choroidal disease compared to a neovascular AMD, typical neovascular AMD. These features may not be present in every case, but if we look for them very carefully and if we find them, we can sometimes strongly suspect the disease even without doing an angiogram. So why should we differentiate these two conditions? It is believed and arguably that both these conditions are entirely separate entities, basically because the natural history and prognosis of polypoidal disease is quite different from wet AMD. It generally has a better chance for good visual recovery, and there is a relatively lesser risk of subretinal scarring, except for cases which are very recurrent and have massive subretinal hemorrhage. As regards the treatment as well, the role of photodynamic therapy has almost disappeared from the scene for neovascular AMD, but it continues to have a role in management of polypoidal choroidal vasculopathy. If you look at retreatment criteria for these patients when they come for their follow-up visits, for neovascular AMD, we typically look at presence or absence of fluid, subretinal fluid or intraretinal fluid. But for PCV, we would also have to look at status of the polyps and to see if they are perfused or non-perfused. Now, how common is this condition in Asia particularly? So if you look at the Caucasians, it's about 10% of their presumed neovascular AMD, which is PCV. But in Asia, we can see that it ranges from about 20% to as high as about 55%. And a study from India also has shown that it's about 49% among patients who have undergone multimodal imaging for serous maculopathy. So this tells us that it's extremely common. Almost half of the patients who present with presumed neovascular AMD have in fact PCV. If we compare the information that we have for patients who are from the Caucasian population and compare that with Asians, we see that in Asia, the disease presents a little bit early, maybe in 50 to 65 year age group. Men are more frequently affected among Asians compared to Caucasians. Majority of the disease in Asia is unilateral compared to a more bilateral disease in Caucasians. And macular disease is more commonly reported among Asians, while in Caucasian population, macular and peripapillary disease is equally prevalent. So to summarize, PCV is about 20 to 50% among neovascular AMD in India. Mean age is about 60, early 60s, male preponderance, unilateral, and a macular disease. Now, is this really a subtype of neovascular AMD? There are arguments in favor and against, and the risk factors are quite similar for both diseases. But as we saw, there are racial and age differences. Clinical features, some of them are quite similar: fluid, hemorrhage, scarring. But we find that the disease is again a slow-growing abnormal vascular network with a relative lack of drusen and RPE changes and a lesser expression of VEGF. Angiographic features can be similar to occult CNV for both sometimes, but for PCV, the vascular network may or may not leak. So that is a key difference between PCV and typical choroidal neovascularization. Of course, both respond to anti-VEGF therapy, but in certain situations, a PCV case may need additional photodynamic therapy to control the disease better. Now, PCV presents in a huge variety of ways. It could be either just an orange-red polypoidal lesion, as you see here in the photograph, or it could be recurrent subretinal hemorrhages, subretinal exudation. Sometimes patients presenting with central serous retinopathy in an age group beyond 50 years should spark suspicion. Breakthrough vitreous hemorrhage or suprachoroidal hemorrhage are also known presentations. And of course, sometimes these polyps are asymptomatic, especially when seen in the fellow eye. We discussed the OCT features, which are seen here. And of course, on angiograms, if you see a vascular network which ends with polypoidal lesions, and if they are seen early in the angiogram within the first 6 minutes on an ICG angiogram, this is quite typical and diagnostic of polypoidal choroidal vasculopathy. The disease can be either symptomatic or asymptomatic. Of course, it can present with acute loss of vision when there is hemorrhage, or gradual progressive loss of vision when there is exudation and fluid leak. So why is ICG important for PCV diagnosis? PCV is a disease which, as we discussed, is an inner choroid disease. So it's best visualized with ICG because of the absorption and emission spectrum of ICG and the high protein binding of the dye. When is a ICG recommended? So it is ideally recommended at baseline if it can be done with a fluorescein angiogram. However, nowadays angiograms are not that frequently done. Doctors usually rely more on the OCTs. Neovascular AMD refractory or suboptimal response to anti-VEGF therapy also is an indication for ICG. And of course, ICG angiogram is ideally recommended for follow-up to assess disease activity. Here are some clinical cases showing various presentations. So here you see a hemorrhagic pigment epithelial detachment with overlying subretinal fluid. The fluorescein angiogram shows a tiny, ill-defined hyperfluorescence, but ICG actually clinches the diagnosis where you see this nodular hyperfluorescence with a notched PED. This is another case which shows dense submacular hemorrhage with some altered blood, and the fluorescein angiogram shows a very ill-defined leakage. However, the ICG shows a nodular hyperfluorescence, which is quite typical of a polypoidal disease. Now, this case could very well pass as a wet macular degeneration. There is fluid in the macula, there are drusen, there are exudates. But if you look at the ICG, you can see these polypoidal well-defined lesions, which are diagnostic and clinch the diagnosis. Here is another atypical case. You see a serous pigment epithelial detachment with some drusen at the edge of the detachment. And on the fluorescein angiogram, it doesn't really show any suspicious signs of activity. So this patient was monitored as was not very symptomatic. But lo and behold, within a couple of months, presented with huge submacular hemorrhage and serosanguinous detachment. And again, the ICG was the one that clinched the diagnosis, where you see this focal nodular hyperfluorescence, suggesting a polyp which is ruptured and caused the hemorrhage. This is another uncommon presentation where patients present with bilateral extensive retinal pigment epithelial alterations suggestive of chronic CSR. So you can see RP tracts extending from the posterior pole downwards. And this patient was being monitored for the RP disease, eventually presented with metamorphopsia, and you notice an orange-red nodular lesion right below the fovea, which shows up even on the fluorescein angiogram, and of course on the ICG shows up a huge vascular network, peripapillary network, and a nodular hyperfluorescence, confirming the presence of a polyp. This case as well can pass on as a typical wet macular degeneration with subretinal hemorrhage and a grayish lesion at the macula. The fluorescein angiogram is not really helpful, shows suspicious CNV, but on the ICG, you see again a huge vascular network, peripapillary network, and polyps. And this was a patient presenting with CSR. So you see a smokestack leak, and you see some fluid pooling in the subretinal space and some retinal pigment epithelial alterations at one edge of this fluid collection. But eventually this patient developed a huge vascular network and multiple polyps and bleed, which then was sort of diagnosed as polypoidal choroidal vasculopathy. And this is the other last case that I wanted to share, which shows massive subretinal hemorrhage, which again is a known presentation of polypoidal disease. Note that the other eye is pristine. There is absence of any drusen or any RP changes suggestive of macular degeneration. So if we want to diagnose this disease, of course, we need a high index clinical suspicion. OCT features can help us suspect PCV, but ICG is diagnostic for the disease. There are some features which suggest poor prognosis. So patients who have multiple cluster of polyps or a larger lesion size, or those who present with massive hemorrhage are, of course, associated with poorer visual prognosis. So what are the treatment guidelines? What are the developments in this field now? Of course, we know based on recommendations that we must treat active symptomatic polypoidal disease. And if the disease is active but asymptomatic, then one can consider treatment based on individual case scenarios. And if the disease is actually inactive, it is recommended not to treat but to observe carefully. The treatment, of course, has now moved more towards anti-VEGF monotherapy because this seems to work fairly well for majority of patients. But we must remember that there are patients who need combination therapy with photodynamic therapy or thermal laser photocoagulation. All the available anti-VEGF agents, including the newer ones like brolucizumab and faricimab, are effective in treating PCV and usually recommended to have a monthly dose till the retina is dry and then a treat and extend regimen. Monotherapy is good for small and thin macular hemorrhages or where the extent of the lesion cannot be defined because there is blood around it, or where there is a peripapillary disease. And of course, if there is a lack of access to PDT because of any reason, monotherapy is a reasonable option to consider. In patients where there is active subfoveal polyp or juxtafoveal polyp, or if there is a suboptimal response to anti-VEGF monotherapy, combination with PDT is currently considered as the favored option. And if the polyps are extrafoveal or if they are peripapillary or peripheral polyps, thermal laser photocoagulation in addition to the anti-VEGF therapy is the preferred option. What is the evidence? This is based on the landmark Everest trial, which compared photodynamic therapy with combination therapy and with Lucentis monotherapy. And this trial really showed that the regression of polyps was better with photodynamic therapy in comparison with Lucentis alone. For the monotherapy, the trials that we look at, the landmark trials are the laptop trial, which compared PDT versus Lucentis, and Lucentis monotherapy showed much better visual acuity gains compared to photodynamic therapy. The PLANET study, which compared Eylea with active PDT or sham PDT, showed that Eylea alone or monotherapy is non-inferior to Eylea with PDT. And the polyp regression with Eylea alone is up to 40%, which is pretty good. And of course, the EPIC trial, which showed excellent visual outcomes with Eylea monotherapy. So what are the newer anti-VEGF therapies? Brolucizumab has shown comparable visual gains with Eylea in the Hawk and Harrier study and a better resolution of fluid compared to Eylea. But of course, there is a concern about severe intraocular inflammation with brolucizumab, which remains. And the drug is not readily available in many countries around the world. Faricimab or Vabysmo has some early results from Japan and shows complete regression of polyps in 52% of eyes. So is very well effective as well. Now, this is one of my cases. I just wanted to share how the management of polypoidal disease is quite challenging and may involve multiple visits. So this patient presented with a serosanguinous or hemorrhagic PED in early 2016, eventually developed multifocal disease, was treated initially with monotherapy, then with PDT, and then another location, the disease started becoming active. And then after combination therapy, the disease was inactive for a couple of years. And very recently, I saw him and he has again developed a subfoveal polyp. with hemorrhage and some exudation. If you look at the angiograms, you can see the fluorescein angiogram at baseline showed a PED and not much else seen, but the ICG did show the polyps. So the polyps were quite close to the foveal center, and hence it was decided to start with monotherapy first. Eventually, the patient was treated with combination therapy and the lesions resolved very well. But there was a new focus of polyps with hemorrhage that developed about a year later, which was also treated and responded well. And now, quite recently, just last week, I saw him and he has a subfoveal polyp, which is seen very well on the ICG angiogram and a vascular network around it. The OCT images for this patient show us the serial follow-up of this patient from 2016 to right up to just recently. And you see that initially the patient was given a Lucentis, baseline vision was 612. Then he received a combination of PDT with around 7 to 8 Lucentis injections. The fluid never really resolved, although the PED flattened. So we decided to give him Eylea at that point. The vision improved to 6.7.5, but because of cost considerations, he preferred to switch back to Lucentis. However, Lucentis was not able to dry the macula, and we had to repeat reduced fluence PDT with Eylea, 3 injections of Eylea, and then the disease quiescent and remained quiet for almost 2 years. And now in July this year, again, we see recurrence subfoveal polyp with pigment epithelial detachment and subretinal blood. So we intend to do photodynamic therapy, reduced fluence with Vabysmo very soon. What are the treatments on the horizon? You have the port delivery system, Susvimo, which has been approved for neovascular AMD, and possibly gene therapy, which aims to actually induce the eye to produce its own anti-VEGF. So in summary, it is important to differentiate PCV from typical wet AMD because the natural history and the prognosis differ a lot. The diagnosis of this condition...
I found this on the web for PCV from typical wet AMD.
Diagnosis of PCV requires a high index of clinical suspicion. Multimodal imaging is strongly recommended. And while OCT features are sensitive for suspecting PCV, ICG is essential for confirming the diagnosis. Monotherapy with anti-VEGF works very well for the majority. However, combination therapy has to be considered if there is suboptimal response. And thermal laser may be required for extrafoveal, peripapillary, or peripheral polyps. Thank you. I would like to thank the organizers, especially Dr. Rupak and Dr. Saurabh Sinha, for inviting me to give this talk in today's Retina CME. It's been a privilege. Thank you. I'm happy to take any questions if there are any.
Thank you, Dr. Wagle, for an excellent presentation. I have one question for you. Out of all the anti-VEGF availables like Eylea or aflibercept and brolucizumab, and now you have access to faricimab, which will be your first choice agent if you have a treatment naive PCV case?
So based on the robust data from Planet study, EPIC study, it seems that Eylea seems to have quite a good polyp closure compared to ranibizumab. I would usually start with Eylea monotherapy. And of course, if it is a subfoveal polyp or if the indication suits low fluence photodynamic therapy, then I will add it on along with the Eylea. I don't have much experience with faricimab yet. I have used it for a couple of patients. It works well, but whether it has any advantage over Eylea is yet to be seen, especially in the context of polypoidal choroidal disease. Avastin, I believe, is no longer a preferred option because, I mean, of course, if cost considerations, it might be considered. But biosimilars of Lucentis as well are available, which can be used and work well.
Thank you. I will just take one more question from Dr. Sinha, Dr. Saurabh Sinha.
Ajit, hi Saurabh here. So,
hi Saurabh.
Going back to the previous debate that we had with OCTA, and I prefer, like you said, ICG. I'm very, I'd love to do ICG in all my PCV patients. And for follow-up cases, would you do an OCTA? How dependent on you on ACTA in PCV cases? Confident, independent, reliable for you?
Yeah, thanks. That's a very nice question, Saurav. And I think OCTA, the challenge for polypoidal choroidal disease is it's not very good for detecting polyps. It can detect the vascular network because there is a fair amount of flow, and if the vascular network is actually active. But polyps sometimes are very slow filling lesions and may not be very easy to delineate just with the OCT angiogram. Traditional ICG angiogram is, I think, much better in detecting and delineating all the polyps if a lesion has to be, properly treated. So I would usually prefer to repeat a ICG on follow-up if there is suboptimal response, or like the case I shared, if there is new findings, new hemorrhage, subfoveal hemorrhage, I would repeat a traditional ICG. I would probably not do a OCT angiogram. A traditional spectral domain OCT itself can help a lot with a lot of features to tell us whether the disease is active. And if ICG is not available, sometimes the OCT also might be enough to initiate therapy. But I'm not very comfortable with OCT angiogram giving most of the details.
Thank you, sir. We'll move on to the next session, that is on case presentations. We'll start with Dr. Anindya Kishore Majumdar. Anindya, can you present your first case?
Good morning, everybody. Today I'm here for the case presentation of viral retinitis. Before going to the case presentation, I am just briefing two issues. Viral retinitis is having a very diverse etiology. The commonest are the herpetic family of viruses, namely HSV1 and 2, VZV, CMV and Epstein-Barr virus. There are so many viruses which are causing retinitis. I am limiting my talk to the herpes family of viruses. So what we look for? If you look at the new Sun classification, they define the acute retinal necrosis syndrome in two major points. One is a necrotizing retinitis that is involving the peripheral retina, that is confluent in nature, and the evidence of infection of either herpes simplex virus or varicella zoster virus. It could be a PCR positive. Or it's a clinical diagnosis characteristic of a circumferential or confluent retinitis. We can appreciate a circumferential and confluent retinitis. For looking at a confluent disease, we need to see the patient at least twice. There is involvement of the vessels, vascular sheathing and optic nerve and a significant vitritis. Exclusion being the positive serology for the syphilis, which is a great mimicker, and if the PCR is positive for cytomegalovirus or Toxoplasma gondii. Again, I am classing a basic case definition of a cytomegalovirus retinitis. There they defined as criteria 1 and 2 and either of the 3 or 4. So the criteria 1 is a necrotizing retinitis with indistinct border and a background of immune compromise, either a systemic immune compromise is a HIV patient or an organ transplant patient or a post-chemotherapy patient, or a local immune compromise, a post-corticosteroid or chemotherapy. And either of 3 or 4, a characteristic wedge-shaped retinitis or a pizza pie appearance or granular retinitis, an absence or mild vitritis, and a PCR positive for cytomegalovirus. Here also the exclusion criteria includes syphilis and intraocular PCR positive for HSV and Toxoplasma gondii. So previously, why I show this, because the ARN previously was defined only in the immunocompetent ones. Now the classification says that ARN can happen anywhere, immunocompetence as well as immunocompromised. When it is immunocompromised, the story is different. Coming to my case 1, it's an old case. 11-year-old female presented with a right eye dimness of vision and floaters for the 10 days. Her best guided visual acuity in the right eye was 624 N36. Left eye was also subnormal. There was evidence of granulomatous inflammation with diffuse vitreous cells. Left eye also having old cells. There is no history of trauma and surgery. If you look at the picture carefully, we can appreciate necrotizing the retinitis involvement of the retinal in the periphery. The media is hazy. There is diffuse involvement of the arterioles and there is significant vitritis as well as ONH involvement. So for this is a case of acute retinal necrosis in the right eye. We look at the left eye, we are surprised that there was a evidence of regressing to the retinitis. So it was actually an asymmetric evolving of the bilateral acute retinal necrosis. So we did an HIV ELISA, it came negative for the patient. We did an AC tap, it was HSV1 positive. We started the patient with IV acyclovir and systemic steroid and good therapeutic response. It was treated long back with a old guideline. So we did at that time the prophylactic bandage just anterior to the margin of the retinitis. It was post-laser in the photograph of the right eye. It was post-laser photograph of the left eye. Unfortunately, the patient can develop in the break and near total RD in the left eye, and reattachment surgery was done. Oral antiviral continued for 3 months. I am coming to a case of a 38-year-old male, a known HIV patient on antiretroviral therapy for the last 1 year. Patient complained of dimness of vision and intolerance to light for 1 month. Base corrected visual acuity in the right eye was counting finger. There was IOP spike and minimal anterior chamber and vitreous reaction. This is very important clinically. So this was the clinical presentation where we can see a necrotizing retinitis. The media is fairly clear. We can appreciate a very hyperemic disc involvement, and we can appreciate retinal hemorrhages. So our provisional diagnosis was CMV retinitis. So we did a AC tap, it came positive for CMV. We started with the oral Valgan cyclovir along with systemic steroid and intravitreal ganciclovir. The base corrected visual acuity improved, and there was upgrading of the vitreous cells. That is a good sign. That is called immune recovery. The patient, when they recover from the gross immune suppression to normal immunity level, there is recovery of the vitreous cells. And their oral vancomycin maintenance was given for a very long time. CD4 count also improved with time. Fellow eye remained normal. So this was the 3 weeks post-treatment in the photograph. Coming to another case of 53-year-old female presented with a dimness of vision and floaters. She was a known rheumatoid arthritis patient, was on different kind of disease modifier. With that, the control was not adequate. She was started with a RA control was good, but suddenly presented with a left eye dimness of vision and floaters. There was AC cells and vitreous cells. This was the clinical picture. We can appreciate a necrotizing retinitis along with a little granular appearance as well, involving the retinal periphery. There are involvement of the blood vessels. The media is relatively clear. There are hemorrhages. So our provisional diagnosis was CMV retinitis. So we rule out HIV. ACTAP was not done because of the financial issues. Started the patient on systemic valcyclovir and intravit ganciclovir, and genosin kinase inhibitor was withdrawn. Coming to a case of a 36-year-old female doctor.
Can you wrap up? How many cases?
We have 1, 2 more. A known NHL patient, she was declared on remission of chemotherapy. She received rituximab and a high dose of methotrexate for CNS prophylaxis. She suddenly presented with the floaters and photophobia. Base corrected visual acuity was stable, but AC has some cells and vitreous cells. If we look at this picture carefully, we can appreciate some amount of sheathing and retinal edema there. We can appreciate early onset of retinitis, which is typically having a granular appearance. So this was also a case of suspected case of CMV retinitis. So we is a globally immunocompromised patient because of the chemotherapy and locally as well. So we did a CMV quantitative estimation. It came high. We started the patient on oral valacyclovir and steroid. PET-CT was to rule out any recurrence of lymphoma. We did a close monitoring, having an excellent response. Okay. So for the etiology, we do aqueous tap or vitreous tap and PCR. It is very sensitive and specific. And in our etiology, the varicella zoster is the commonest organism. HSV more common in young, HSV2 more common in aged, cytomegaloid in immunocompromised background. This is our tailored treatment outline. Thank you.
No, I have a question on Indo. So when do you suspect viral retinitis? Because see, yellow lesions in retina can be choroiditis also and can be viral. So can you just give us 2 to 3 points where you suspect
like
this is a patient of viral?
Typical pattern of the clinical appearance, yellow lesion starting in the periphery, circumferentially spreading, ill distinct in the border, and history is very important. Whether the patient has any history of any immunocompromise or in a chronic chemotherapy or a chronic diabetic in the patient, and then clinical assessment. How is the vitreous into reaction? How is the anterior chamber into reaction? From that we can do suspect. We can correlate with, we can do OCT, section taken on the top of the lesions. Even we can do FFA to confirm if it is a very small patch of the retinitis. Many of the times it is confusing whether we are dealing with a choroiditis or a retinitis. We can have a typical appearance in FFA. We can diagnose in that case.
Any comment for Dr. Devashish sir?
Valganciclovir, you told that it used for long time.
Valganciclovir is a CMV specific oral antiviral.
Yeah. How long you are using?
Sir, in the loading dose, we give 900 milligram twice a day.
Okay.
For 2 to 3 weeks. We have to closely monitor the patient. We need to see 3 things. One is clinically we are seeing valganciclovir is a very toxic drug. Means the ganciclovir molecule is very toxic. So it can create bone marrow suppression as well as it can affect the kidney urea and creatinine. We closely monitoring the patient clinically as well as from the laboratory parameters. We continue the loading dose for the 2 to 3 weeks time. After that the dose is half, 450 milligram twice a day. There is no clinical consensus for how long this dose should be continued. It should be continued at least for 3 months. Many of the studies have suggested if it is a one-eyed patient, one eye is lost due to necrotizing retinitis, the other eye is having the same similar kind of issue, patient may require this antiviral prophylaxis for a long time, even for the lifetime. There is no consensus for the maintenance therapy duration.
Okay.
Will there be any biomarker for maintenance therapy? CD4, CD8?
Yes, sir. If it is a valganciclovir, there is improvement in the CD4 in the count.
Correct. No, I wanted to keep it as a message to the house. Yeah.
It is specific for the HIV patients. When we treat HIV background CMV retinitis, CD4 is one of the very important in the biomarkers which rises with time, and this is also very important when we give the CMV retinitis treatment in case of HIV patient. The ART therapy has to be given along with, because CMV pathology and the HIV pathology are go hand in hand for each other and facilitating each other's pathology. So we are giving anti-CMV treatment for CMV direct and as well as the ART. And CD4 increase is one of the biomarkers and one of the indications where you can stop the anti-CMV in the treatment or the low dose maintenance.
Thank you, Dr.
Thank you.
I request Dr. Kalpita Das to come and present her case. I think we can take one question from Anirban.
Now, and I keep it like that because it was an old school of that. Once the laser was thought to be beneficial, so the thought behind was if the barrage is done anterior to the area of the affected retinitis, it will restrict the continuity of the retinitis from coming to the posterior pole.
But I just want to add. So what we used to do is, the idea was that if the peripheral retina is necrotic, there is a risk they will develop retinal holes. Yeah. So we used to barrage the retina posterior to the area of the necrotic retina.
But I think nowadays, in fact, barrages can itself induce a retinal detachment because of the necrotic retina. So yeah. I don't think nowadays.
But previously we all used to do this.
This is a documentation from the previous records.
Because of the change in trend of the treatment, I keep it there because we used to do it like that. Nowadays, laser is not done.
Correct.
At the outset, I would like to thank YSWB and RKB sir for this opportunity. So today I am going to discuss an interesting case of CSR who presented with a RP rib. So a 60-year-old lady presented with gradually progressive painless vision in the right eye for 6 months. She had some history of laser done elsewhere 3 months back prior to presentation, and she was referred to us as a case of phlegmatogenous retinal detachment. Clinical history, she was a hypertensive and patient of ulcerative colitis. So in the fundus photograph, we can see there is an retinal detachment in the inferior part. At the macula, there is a large area of RP atrophy and some area of lesion in the temporal periphery. So when we examined the patient vision was 1/60. When we examined the patient clinically, there was a presence of shifting fluid. So this was an exudative RD, and we could not see any clinically, we could not see any break. So this was not a case of rhegmatogenous retinal detachment. Left eye had, we can see, was grossly normal, vision was 6.5 and 6, but we could see some area of RP alterations in the macula. We did an ultrasonography thinking of if there is something subretinal. Ultrasonography showed positive shifting fluid sign and no mass lesion. Interestingly, when we see the red-free image, we can see there is a large area of RP defect temporal to the macula, and in between there is a hyper place, this is the scrolled RPE there. Autofluorescent again showed a hypo-autofluorescent compared to the area, suggestive that the RP was completely destroyed in that area, and we could see the scrolled RP in between. We did an angiography which showed the early hyperfluorescence with a pooling of the dye and multiple tiny leakage spots at the edge of the RP atrophy, which gave us the diagnosis of a CSR in this case. Other eye also showed multiple pinpoint hyperfluorescence suggestive of CSR. OCT, in this OCT we can delineate, if you see through the vertical scan through the area of the RP defect, we can see there is a loss of RP in between, so this is a large area of RP rip. Left eye also had presence of subretinal fluid. Left eye didn't have that, otherwise the subfoveal subretinal fluid. So we went back, asked the patient about any history of steroid, we asked the systemic medications, then she disclosed that she was on and off inhalers for breathing difficulties. So with all those clinical clues, we diagnosed this case as a large right eye, large RP rip presented as an inferior bullous retinal detachment associated with CSR. In presence of a large RP rip, we preferred the patient to observe, and we seek pulmonologist opinion for alternative or steroid inhaler. So after 6 weeks, when patient came back to us, we could see there is an area of large fibrin at the edge of the RP rip with a central black dot, which clinically we see as a black dot sign. And when we did the FFA, we could see a large leak at the center of this fibrin. So at this point, and left eye was almost similar. And when we did the OCT, we could see the fibrin in between the vacuole, which is described as a vacuole sign, and the RP rip we could see in this area. Left eye was normal. At this point, we decided to do laser to the leak. And we, with the laser, so with that laser, patient resolved well. 3 months, patient had a vision of 6/60. I have a 5-year follow-up of this patient. Patient is maintaining 6/9 and 6 vision, even though she had in between recurrence of fluid, because for the breathing difficulty, she had to take on and off steroids, but that resolved with when she stopped the steroids. So with this we know that RP tear can present as a bullous retinal detachment in CSR, which leads to sudden vision loss. And corticosteroid treatment definitely increases the risk of RP tear in CSR because it increases the hydrostatic pressure within the PD, and fibrin, again, it increases the circumferential traction within the RP. And multimodal imaging definitely helps us to diagnose RP rip and in bullous detachment in other cases. And RP tear usually has a spontaneous reattachment because of the migration of RP from the denuded edge of the tear, or by formation of a fibroglial tissue, or from the outer retina and Brooks membrane. But we need to treat the underlying disease process for a better visual outcome. So my question to the house would remain that RP rip in CSR, whether you would like to treat in the beginning or to observe, and if you need to treat, when you treat, and is there any role, any situation you can prevent RP rip in CSR? Thank you.
Very excellent case, excellent documentation. I'll seek opinion from Dr. Shubhankar Sri. Can you just, what are your thoughts on RP rip in CSR? How common is it? And whether does it really need any treatment?
I haven't seen a case of RP rip in my this thing, but what I feel that there was a history of laser treatment done before. Was it a cause of RP rip?
Patient presented with a acute onset of loss of vision. So laser was done long back, so did not have a very clear history, but I don't think the laser per se had caused the RPD, because that was not any recent history of laser previously. Laser was done quite a long time back.
And
because I feel she had a bout of breathing difficulty for which she had a steroid, an increasing dose of steroid has caused this RP rip for that particular patient. Because when she presented for the 6 weeks follow-up, so she had stopped taking the steroid.
Yeah. So I think the RP rip was temporal.
Temporal to the macula.
Temporal to the fovea, so it was not vision threatening at that point of time.
Yes.
But the only interesting thing is that your leak was within the fibrin. So how difficult was it to laser that? Because in a fibrin, whenever you try to do laser in a fibrin, there is a lot of reflection that I have seen.
Actually, clinically, if you've seen this fibrin and there's a central dark spot, it has been described in the literature, that is called the dark spot sign, and clinically you know that is the point of the leak. And because in the fibrin there is a vacuole there in between, so actually laser, it's risky.
So my question is how to assess, because the fibrin is yellow, and your laser spot also we see blanching of retina or with little white spots. So what I have found it difficult when I do laser in a fibrin, I cannot assess how much.
There is actually no fibrin in that particular, in the central dot. So actually you can do laser there. Yes, you can, because there's a vacuole in the center.
Very nice presentation. Actually, I had a similar case. I had presented as a OSWE poster last time. But in my case, unfortunately, I had a total bullous retinal detachment, so no shifting fluid. I couldn't locate a break. But once I entered and I found no swirling sign, nothing. So I knew it was a non-resolving exudative RD. So after I settled the retina with a retinotomy, I found around 3 to 4 clock hours of a RP rip. So that was quite a huge rip. So even in my case, I probably, on hindsight, if I would have done an angiography, probably I would have some more pointers. And in my case, the other eye had a scar temporal to the fovea, could be a polyp or could be a resolved polyp. So, but what should be your plan of action if you have, say, a exudative RD which has been lying around for, like, say, a month and a half, which is not resolving? So would you go for surgery, or would you like to, because laser is not possible, or would you want to give a trial of anti-VEGF and then go ahead with it, surgery?
If it is an exudative RD, there is no role of surgery there. I would prefer to observe, and I will do an angiography and look for, and in a serial follow-up also, because for this particular patient in the first instance, I didn't do anything. When she came back with the fibrin, that time I decided, because it didn't resolve for 6 weeks also, I plan to do a laser for that particular patient.
Should our protocol then be, if you never, like, there are cases which you don't find a break, so should we be doing?
So I had seen one patient with Dr. Lingam Gopal there. Patient came from Iraq with a blast injury and multifocus CSR in both eyes, bullous huge retinal detachment lanes touching the retina. So then those cases, sir, did a SRF drainage there from an external approach, not an internal approach.
Exactly. There is no role.
Naresh sir has a point.
Okay. Yeah. There is no role of converting an exudative retinal detachment. There is no question of converting to a reg RD.
At that, when I entered, I was suspicious that I am not finding a break. So I entered it thinking it to be a regmatagenous bullous detachment, because it looked completely like a bullous detachment. So, like, secondly, I have seen some cases which are actually regmatagenous detachment, which have been going around for 8 months, 9 months, and I had to operate and I found a break. So both path of the story is true. So should we be putting angiography as in a protocol whenever you don't find a break to go ahead with it?
Yeah, if there's a exudative RD still, it's like shallow, then bullous, but still you can get an angiography. But the case I'm mentioning had a blast injury in Iraq. The patient had a huge exudative RD touching the lens. So I don't think for that particular case, angiography also would be of much help. But particularly with the case, I think angiography should be done to look for whether, like, whatever the exudative component, because exudative RD can be because of other reasons other than CSR also. It can be some mass lesion, it can be inflammatory pathology like uveitis, like that. Please, sir.
Actually, we had one case of RP rip. Patient was 6'9" when presented with PED with fluid. After one injection of anti-VEGF, massive rip over the macula. Actually, we have gone for a surgical management. We did a submax surgery, induced RD. We made the RP transplant. I think that video we got the best in APVRS the previous year, 2021, I think. So from 6'9", patient was 3/60, but now is maintaining somewhere around 6'18". So some rips can be still managed surgically, should not be an issue. And we had a different experience in managing exudative RD. There is no contraindication if the exudation is not getting out, because we have to rule out type 3, UVL effusion syndrome, because that may be confused with the CSR. There the axial length may be normal, even the sclera will be normal, but the matrix of sclera will be difficult, right? In such cases, it's difficult to do scleral window, but in such cases, when we go for a vitrectomy with the tamponade, it really helps. So we have to keep in mind type 3 UVL effusion syndrome also in these cases.
Yeah, I think Dr. Vipin Rana wants to make
Ma'am, excellent cases. And this is just regarding this fibrinous CSCR which you just presented. Just wanted to share my experience. Like we have seen few cases where the fibrinous CSCR was misdiagnosed as chorditis, and patients were started on the oral steroids. They did not respond to the oral steroids. It increased. They were started on immunosuppression and finally on the biologics. So, there's a paper which has been published by the PGI group which shows this dark spot which is beautifully shown by the ma'am, and also the vacuole sign on the OCT. So the misdiagnosis has to be avoided.
So,
excellent cases.
like moral of the story would remain that we need to investigate this patient properly to look for the diagnosis and then decide about the treatment.
Hello. Okay, she's getting ready. So just a quick comment that even if it is bullous retinal detachment also, and if you have a doubt whether it is a exudative or regmatogenous, you can take up the patient, you can do an external drainage, and on table you can see whether you can locate the break or not. So if you do a significant amount of the fluid drainage and needle drainage, even after that also you are not able to locate the break, then look for the macular hole very clearly. So there may not be a peripheral retinal detachment, there may be a macular hole which is leading to the regmatogenous retinal detachment. So even if you are not seeing there any break, so better not to venture for the initially as a vitrectomy. So then if the fluid is absorbed, just sharing one case Dr. Sinha and me are doing right now, is an 85-year-old gentleman and having a raised PSA level. So we were suspecting that the patient is having a micrometastasis in the in one eye and having an exudative retinal detachment. So we did a needle drainage and did a cytology of that patient. Turned out to be no malignant cell, but in 2 weeks' time, the patient has completely settled down and there is no fluid at all. So there is a significant role for exudative retinal detachment, that if you can do a good resolution, because the RP function is not able to pick up of absorbing that amount of the fluid. So if you reduce the fluid, it goes off, and then you do a fluorescein angiography to detect the primary cause.
Okay, you can start.
Good afternoon, everyone.
Your screen is not visible.
Good afternoon, everyone. Thank you, Rupak sir, for this opportunity. I'll be presenting an interesting but a challenging case of dull yellow lesions at the macula. So my patient is a 48-year-old gentleman who presented with 5 years history of gradual onset painless diminution of vision in both eyes. He's a known hypertensive and diabetic, and best corrected vision in right eye was 2418 and in the left eye 2218. Anterior segment examination was normal. On fundus examination, we found that there were some macular changes which could be better appreciated on a magnified image. That is, there was loss of transparency in the parafoveal region in both the eyes, and there was some macular deposits, yellowish deposit, which was more prominent in the right eye inferiorly, and on the left eye it was more distributed in the center. On the NFAS, we could see that the vessels, some vessels which were running towards the center, and they were dilated and not tapering down as it should be, and they dive into the deeper layers. And this was more obvious on the right eye, but one vessel could be seen on the left eye too. When we did the fluorescein angiography, we could see early capillary telangiectasias, and on late frames, there was evidence of late leakage and staining. The octa of the right eye was very characteristic, with the vessel, blunted, dilated vessels near the macular center, and there was capillary telangiectasia. Whereas in the deeper slab, when we go in, we can see that there were presence of this larger caliber vessels in the deepest section too. And this vessel, actually, all the other vessels were drawn centripetally towards this network, which is very characteristic of PFT. These findings were less prominent in the other eye, that is the left eye, but even then we can see some blunted venules on the octa in the superficial slab.
On the OCT, what we can interestingly see is that there's loss of lamination, retinal lamination on the temporal side of both the eyes, with loss of ellipsoid zone and the outer nuclear layer. And there's a mild presence of SRF in the right eye, and there is intraretinal cavitation in the left eye, and loss of outer nuclear layer in the left eye. When we look at the autofluorescence, it is when that we were taken back, we could see there was in PFT, what we expect is that because there's loss of luteal pigment, there is unmasking of the hypofluorescence center. So it should be, the fluorescence here should be almost equal to that of what we see in the parafoveal region. But as in our case, if we see, there is significantly high amount of autofluorescence that we can see in both the eyes. With that, we went into the OCT scans and we were looking very carefully as if to see if what is the characteristic of this deposit. So when we looked at this region, we could see that there was deposit, subretinal deposit between the RP and the neurosensory retina, which could easily be picked up on this OCTs. This was for the right eye and this is for the left eye, where we can see similar RP deposits between the RP and the neurosensory retina. Thus, we were thinking of a best disease component in it. So we did a EOG which showed that the Arden ratio was more than 2.15 in both the eyes, and there was no history of similar complaints in other family members. So taking the vascular component as well as the vitelliform deposits, we likely made the diagnosis of a vitelliform deposits in MACTEL-2. And the other differential that was kept is adult onset vitelliform macular dystrophy with a PFT component in it. We went into the review of literature to see if actually there is any evidence of vitelliform deposits in MACTEL type 2. So this is an article beautifully describing in BJO 2012, where they showed that this is an uncommon finding that is seen in only 5% of the eyes, and this is present between the RP and the ellipsoid, and this is hyperfluorescent. And what they have found on ultrastructure, that is the biochemistry analysis, that they actually are degenerated photoreceptor elements. So with this, the management of this case was that we have kept the provisional diagnosis as PFT with vitelliform deposits with no CNVM in OU at present. We explained the patient about the disease condition and the natural history. LVA trial was suggested. We have advised to keep him his diabetes and hypertension under control, and we will follow up the patient 3 to 6 months to see how the disease behaves to confirm or refute our diagnosis. So to take home messages, some subretinal vitelliform deposits may be present in a very small percentage of patients with PFT. Autofluorescence imaging is a highly sensitive modality. SRF, when present, may be erroneously attributed to CNVM, and OCT slabs should be corrected for retinal substitute for CNVM diagnosis. So the points to ponder is that if this subset of patients who actually have this excess shredding of photoreceptor segments have a poorer outcome in the long run as compared to those who do not have this. So could it be a poor prognostic biomarker in PFT? With this, I would like to end, and I would like to thank the imaging team at Shushut for helping me out with this presentation. Thank you. I'll be happy to take any questions.
Thank you, Mukesh. Very nice case, very novel case, and very nice documentations. So vitelliform diseases, lesions are not being described with lot of diseases actually. So I think it's an end pathway of retinal degeneration in many. So we have seen patients with Stargardt disease also present with vitelliform. But you're right, we don't know whether this subset has a poor prognosis or not. But it is important not to misdiagnose this as a CNVM.
Yes, sir.
Yeah, that is the main important thing, because PFT there is always a suspicion of CNVM, and you can see a RP elevation like thing. Somebody can miss it as a CNVM and inject. So autofluorescence is very important to pick up that this is a vitelliform lesion, not a CNVM, and observe.
Yes.
So we can take one question, and Dr. Vipin Rana.
So this was a very, very interesting case. Compliments for the nice case. And I think, these acquired vitelliform lesions have been described in the CSCR in cases of the large drusen, and in cases of the MACTEL also, as you said, in 5% of the cases. Because whenever there is a gap between the photoreceptors and the RP, so this potential space is subretinal space. Then this shedding of the photoreceptors, as rightly said by the sir, that degeneration of the photoreceptors. So it keeps getting accumulated. So I feel that instead of the adult onset vitelliform dystrophy, it is more of this acquired vitelliform lesions in cases of the MACTEL, which has been described in the literature.
Yeah, I think that is what he has labeled it as, PFT with a AVL, that is acquired vitelliform lesion. Yeah, excellent. Thanks, Mukesh. We'll move on to Dr. Sudipto Das. Sudipto will present an interesting case.
So whatever dilemma we have only 6 minutes to discuss. So I'll have, thank you so much, Dr. Rupak Vishwa sir, for this opportunity, because we had this confusion because this patient was sent to us with the diagnosis of suspected CRVO, bilateral CRVO. So any differential diagnosis from the house? So this is optic disc edema. I think few of us probably have seen this patient. Optic disc edema, flame-shaped retinal hemorrhages, macular exudates, corneal spots. We have a lot of features of hypertensive retinopathy. This patient, 23-year-old male, both eyes dimness of vision, 6'9", 6'18", patient of IgA nephropathy, stage 5 CKD, creatinine was 10, awaiting renal transplant, uncontrolled blood pressure, and was on a treatment on hemodialysis. Anterior segment was normal. And this was the picture with, if you can see a montage. And there was inferior exudative retinal detachment also in this patient. So this patient was diagnosed elsewhere to have hypertensive retinopathy. His blood pressure was being treated. This was the B scan, which showed exudative RD, shifting fluid. And this was the OCT, cystoid edema, neurosensory detachment. You can see multiple hyperreflective dots in inner layers. And this was the initial approach. So this was the initial prescription of bilateral quadri CRVO. We thought of IgA nephropathy induced by malignant hypertension, Lyme or Cascade of hemorrhagic diseases. Investigations, FFA couldn't be done because of this high creatinine. And we asked for nephrologist opinion and we waited so that hypertension can be treated. So no improvement despite intense control of hypertension. So did we miss anything in this patient? So now we go to the photograph. Probably we need to have a different algorithm, our own intelligence to think that sometimes we miss few things, we take it more generalized. This patient had a history of contact. Anterior chamber was quiet. There was minimal vitreous cell in this patient, and there were few, you can see very tiny, some well circumscribed plaque-white lesions in the right, this area, and left also. It's not very obvious here in the photograph, but once we searched, we thought that probably you're missing something in this patient. So we thought of probably there is a non-necrotizing retinopathy in this patient because of those plaque-white lesions, deep lesions. 27 gauge vitrectomy, biopsy done, PCR was done for virus as well as MTB. Nested PCR came positive for HSB2, so we thought had made a provisional diagnosis of non-necrotizing herpetic retinitis in both eyes. Tablet valsipir was given 500 milligram because of his renal compromised status, and because of that only we thought of giving intravenous ganciclovir after 3 weeks of starting valsiclovir along with oral steroids. These are the few literatures. Most of the time it was vitritis, retinal arteriolar sheathing. In our patient, it has corneal spots, bilateral hemorrhages as well as exudative retinal detachment with macular plaque-white lesions. So this was the OCT after 3 weeks. If you can see that it's resolved significantly, minimal subretinal fluid, hyperreflective dots are already gone, and this was after almost around 4 months of therapy. Vision was 6 by 7.5 and 6. Few dots in the right eye, left eye was almost normal. So to discuss, HSB can cause anterior uveitis to ARN and have rarer atypical forms of slow ARN and non-necrotizing retinopathy. Atypical viral retinopathies can have granulomatous anterior uveitis, arterial sheathing, vitritis, vasculitis, and or papillitis, focal necrotizing, non-necrotizing retinitis, but absence of retinal necrosis, which is important. And our case was unique. It had vitritis, vasculitis, papillitis, exudation, exudative RD, along with focal plaque-white non-necrotizing lesion because of HSB. This was published, but it was published in that we thought that it's IgA nephropathy with end-stage renal disease with superadded viral retinitis as a rare case report. So to conclude, we cannot miss atypical subtle clinical signs in patients with multi-system disorders, which is very important in this patient who present with a spectrum of clinical findings. It is essential to investigate thoroughly in order to rule out other differentials which simulate the clinical picture. And PCR for viral DNA using diagnostic with biopsies and ACTAP in case you have AC inflammation is an important adjuvant investigation in diagnosing posterior uveitis. Thank you so much for your patient hearing. These are my acknowledgements.
Thank you, Sudipto. Excellent case, because most of the people will think it and treat it as a hypertensive retinopathy only and stop there. So, and such a good outcome. An opinion from Dr. Devashish Das.
Excellently documented and managed. Great.
So, can you just show us which placoid lesion prompted you to do the vitreous biopsy?
That was on the right eye, superior temporal arcade, I think.
So this actually is the lesion, which is not very obvious here. Maybe in laptop it's much more clearer. And here it was one here. This one actually is more important. This picture, this was. So it was quite a deep lesion. Once we started thinking that we are missing something, then it was a
deep retinal
lesion.
Anindo, you want to comment on this? It's a viral retinite. So most of us will treat it as a hypertensive retinopathy with a clear history of.
Here. There was very, even also here, very subtle vitreous cells, because being retina persons, we were not paying
Exactly. We often miss, because hypertensive retinopathy
and the
grade 4
picture
is very unlikely with any sign of inflammation.
And this
Whenever there is
patient,
any
when
sign
comes
of
with so much of systemic situations, you always feel that it's hypertensive retinopathy.
Yeah, I think that is the key point, that if we say even one cell, then we have to think something
And the other thing
else.
is that patient was already under treatment, so blood pressure was not very uncontrolled. It was not very high.
Exactly.
When the patient came to us, he was already under medications. But we thought probably it's a sequelae, it's not resolving.
That's true.
Retinitis like pictured, they suspected actually.
So this is the placoid lesion, which was quite prominent in the right eye. Angiography was, because his creatinine was 10, and nephrologist didn't. He was on hemodialysis, but nephrologist didn't allow, because he was awaiting kidney transplant for IgA nephropathy. No, that because we have not taken. We have taken this OCT before. When we thought of this condition, that time OCT was not taken.
Okay, thank you, Dr. Sudipto. For want of time, we will not take any more questions. We will go to our next speaker, Dr. Somnath Chakraborty. Somnath, he will please start, present your case.
Thank you, and at the outset, I thank Rupakda and OSWB for giving me this opportunity today. So going straight to the details of my case, she was a 74-year-old female who presented to us with complaint of poor vision in her left eye since 1 month. Her BCVA right eye was 6/12, left eye 6/24, and anterior segment evaluation was normal. Her right eye fundus picture showed multiple druseness of large to medium size, which was confirmed on OCT. Left eye showed a large PED with a suspected macular hole. So on OCT, there was indeed a large, tall PED of 531 microns, and there was a medium full thickness macular hole, and there was also a pre-existing vitrofoveal separation. So based on these images, we diagnosed her as a case of a macular hole secondary to a large PED in the left eye. Now there are multiple reports of macular holes secondary to PED in the setting of neovascular AMD. The possible reasons for this are tensile pressure of the underlying PED on the retina, a retracting force within the PED as the fluid of the PED resolves, leading to a formation of macular hole, a rupture of intraretinal chronic cysts secondary to the wet AMD process, leading to a macular hole, and glial apoptosis. In our case, we felt that because of the large, tall PED, it stretched mechanically the retina, which was already edematous due to the presence of the wet AMD, and led to the formation of the macular hole. So how do you treat such a case? So there are two case reports of surgical management of patients of macular hole with large PED. And there is one case report where Storch et al. Treated such a similar situation with a single injection of bevacizumab. Now in our patient, we decided that we'll go for anti-VEGF injection. We didn't prefer surgery because the PED was very tall. We were worried that we may actually end up damaging it while trying to do a vitrectomy. Second, there was already a pre-existing PVD, so we felt that probably it is more of a question of something pushing the retina and causing the hole, rather than something pulling the retina and causing the hole. Now, as for the injection, we didn't prefer bevacizumab. We opted for brolucizumab. The reason is, one, we know from the recent Hawk and Harrier trials that brolucizumab appears to have probably the maximum effect on the sub-RPE fluid. It definitely outperformed aflibercept, probably because of the smaller molecular size of the drug. And we have also recently now published a real-world case series of brolucizumab being a very safe and efficacious way of handling large PEDs. So 1 month after the brolucizumab, this was the fundus picture. The hole appeared closed, and the PED also appeared to have flattened a bit, which was confirmed on the OCT. So you can still see there was intraretinal and subretinal residual fluid, but the hole had closed, and the PED height had also reduced. Now again, based on our experience in the real world, especially from Eastern India, most of us who are using brolucizumab, we usually have seen a sustained effect. So at this stage, though there was still residual fluid, we thought we'll wait and watch. And sure enough, by 3 months, the PED appeared to have disappeared and the hole was still closed. And the OCT showed a very small residual PED of only 116 micron and a very well opposed macular hole. So this is a quick recap of the case. That was the picture at baseline. This is after a month. Patient had initially improved from 624 to 618, and at the final visit, she had improved up to 612. So the take-home messages is, so we have presented a case of a macular hole secondary to a large PED, which we treated medically with intravitreal brolucizumab. There was improvement in the PED morphology post-injection, and this has been seen even in other settings of when we using brolucizumab. And probably this relieved the mechanical stress on the retina, leading to approximation and closure of the macular hole. Thank you so much.
I think this is an excellent case. I have never seen such a case, and I would never think of giving injection, not doing. But this is a very great learning point. I mean, if I see a case like this, I mean, excellent case. Any opinion? Anybody has seen a case?
I want to make a point over here, Dr. Somnath. Can I have the last?
Yes.
Long back, Somdatta has posted a case like this in our group. I don't know what happened to that case. But this is an excellent result.
At the end point, the EDI was very thick. The choroidal thickness was still very thick, and which has a chance of recurrence. You need to follow up these cases every 3 months.
Exactly. So what has happened? This is the tragedy of real world.
Yeah.
You have pointed out exactly true.
So basically, you have to follow the choroidal thickness.
Correct. Because the neovascular AMD is probably still something that we need to do more about.
Yeah. So this is not the end of the story, Rupak.
But the tragedy is
this will evolve further. See, look at the thickness of the choroid.
We cannot claim that a single injection of brolucizumab will cure neovascular AMD. That is not the message that I want to give. Correct. I just want to say that not all macular holes need surgery. We have to see what is causing the macular hole. Exactly. In a secondary macular hole like this situation, this is the second report. There was one report of Avastin closing the hole. We have recently published this in IGO case reports. So this is now a second report. But as correctly highlighted by Dada, that we have to keep looking at the wet AMD, which can still definitely come back and
the choroid is still thick.
That is correct. That is.
She wants to make a point.
I had a story which is the reverse of that. I was treating a PED like this, and I gave an anti-VEGF, and I had a hole at I think a follow-up, and I told the patient, even I was confused what to do. Let's wait and see. Third week, that is 6 weeks post-injection now. So the patient's hole had closed spontaneously. So I was like, oh,
very correct.
God saved me, God saved you. So I was quite happy, and I didn't go for surgery. Yeah. So I think the take-home message should be like probably wait and watch for a while also in some cases when you have the reverse story, like the macular hole precipitating in such a high PED. So the reverse, my case will be probably because of contraction.
See, that's what you have done is exactly what we have done. We have focused not on the hole, but on the PED.
Pathology, yes.
Yes, and so we go after the PED, and as Dada has said, that we have to keep going after it because the wet AMD is still there. The hole is a secondary thing, so we didn't think that this is a case of macular hole, but it is a case of wet AMD. Yes.
Yeah.
Thank you.
Yeah,
Thank you.
Not resist myself of talking in this macular hole. See, there are two pathologies are lying together.
Yes.
One is primary pathology, which is causing the PED, and macular hole, which is secondary to the PED. Now, in this kind of situation, this is something like the macula is like this, and you are trying to push macula, So this is a stretch macular hole, which is actually the phenomenon of traumatic macular hole also. When you have a blunt trauma, you have a concussion injury. So when the traumatic macular hole, why it occurs? Because of the sudden increase of the posterior pole, the stretching of the posterior pole because of the thrust, so and then sudden increase and then decrease, that causing the macular hole. So this is the dynamic is usually changing in case of traumatic macular hole also. So what we are doing, we are giving 3 months of time to again to close it. So majority of the traumatic macular hole closes down by 3 months time. So here also, once we are very lucky that without RIP, the patient, the PED has flattened down.
Correct.
So once the PED flattens down, automatically the stretch factor goes off and the retina comes together. Correct. And that's how it closes. And if you see the chronology of that, so initially the gap, then the gap closes, but again the normal architecture is not maintained. The more and more the PED is flattening down, it is normally almost getting the contour. Correct. So this is how exactly the retina behaves in case of similar macular hole. But there are reports of RIP also has reduced. So correct. Even with the RIP also, but vision has come down, but RIP also can do this.
Excellent.
Thank
you all the panelists and chairperson. We'll move on to the last session. I'll request Sangeeta.
Thank you, sir. So without much delay, we will start the next session, which is a surgical retina session. I would like to request Dr. P.N. Bishwas, sir, Dr. Shondeep Mitra, sir, and Dr. Tushar Kanti Sinha, sir, to please come on the dais and chair the session. And I would like to request Dr. Vivek Datto to please come and join us for the panel discussion. Dr. Saurabh Sinha, sir. I think he's outside. Dr. Arnab Dash.
Most of the time he is waiting outside. Outstanding retinal surgeon.
Dr. Shaptoshi Majumdar. And Dr. Zahir Abbas.
Tawhid, can you call Dr. Sinha?
Dr. Saurabh Sinha, sir, by the So our first presenter is Dr. Rupak Kanti Bishwas, and he will talk on a very, very important topic, nucleus drop. Drop nucleus, what to do?
Yeah, now this is again for the Journal of Ophthalmology, most of the today's program. So we'll keep ourselves restricted to that part, most of the things. I don't have any financial disclosure for this particular talk. Let it be very precise key to do and what are the things not to do. I think the later part is more important. So as a surgeon, initially we learn what to do, and the next part is what not to do is the most important learning for a surgeon. So here also similarly, so if you have this kind of situation, you can always extend and take out the dropping nucleus and take it out by different method, fish hook technique, or by putting a needle and then putting it up and take it away. Yes, everything is fine unless and until you are disturbing vitreous that much. So this is the most, I think, take-home message. What I have, I'm to starting with. I'm also giving the same message, and I will at the end also I will stick to that. Or you can always, consult with a VR surgeon who is available in your hospital, or you can have saved in your mobile. So let us have the 3 scenario. When you have a PC rent and you don't have the vitreous prolapse there, so an anterior segment surgeon, Dr. Arup Bhomik anyway, he can take care of everything, but any anterior segment surgeon can take care of this situation and just do this, complete the surgery very well. So this is a gray zone when you have a PCR and you have a vitreous prolapse, but there is no lens matter in the vitreous cavity. So the vitreous cavity is still yet undisturbed that much, except the some amount of the vitreous has come up to the anterior chamber. So the third part is that you have a PCR or partial or whole lens as in the vitreous cavity. So here the role of vitreoretinal surgeon only is there. So I mean, let me be very clear about. So 1, 3 is very clear. Second part is in the little gray zone. So we'll come to that part. First thing is that do not panic. So whenever this situation appears, and it appears for any surgeon, whoever is denying it, either he is telling lie or he has not done the surgery, or most important is that at that point of time, do not allow the AC to collapse at that much. So more the turbulence occurs, some more amount of the vitreous starts coming. So use significant amount of the viscoelastic agent to tamponade as much as vitreous as possible, and assess at what stage you are. This is very important. So at that point of time, if you can assess that whether how much of matter is left and how much matter is in the vitreous cavity, how much matter is still in the bag, whether some amount of in the anterior chamber. So by that way, you need to decide it how to proceed about it. If you have a significant amount in the anterior chamber, which you can always, slowly extending your limbal section, you can take it out that much, see how much is in the vitreous cavity, how much is in the bag. To note for the vitreous cavity, do not assume that I have only small piece of vitreous cavity, lens matter in the vitreous cavity. Do an indirect ophthalmoscopy on that point of time if possible and see how it is. At that point of time, if you need to talk to your VR friend, do not hesitate to talk to VR friend that this amount of the vitreous cavity is still there, and this is where I am stuck now. Now, whether if you have a very least amount of the vitreous cavity or a cortical amount, some amount of the cortical matter in the vitreous cavity, so probably less than 10% of the cortical matter in the vitreous cavity, less than 10% of the cortical matter only in the vitreous cavity, still you can manage without doing a vitrectomy if there is not much of postoperative inflammation. But again, that depends upon how the postoperatively eye behaves. But I'm discussing mainly for the on table. So if you talk to your VR friend and then decide what stage it is and whether the IOL insertion is at that point of time is needed or not. If your VR friend is, they have some good amount of the vitreous, nucleus matter in the vitreous cavity, and they have the phragmatum there, you can put IOL. If they don't have the phragmatum, then always there is a possibility that he has to take it out through the limbal route of that matter, then don't put IOL. So this should be a hand-in-hand technique, or rather shake-hand technique to discuss with, and then decide about the next plan of action. The standard approach is, the standard approach is whenever you have, so you do a vitrectomy from the pars plana route and try to do as much as, if you try do, the more of a hydration occurs and most of the vitreous starts coming up. So more you do, more it starts coming up. So rather you can do in a different way and see if you go in the vitreous cavity and then just lie behind the PC capsule, and then you can just create you take the vitreous behind it, and you have already created a vacuum there, and you are separating this part of the vitreous from the part which is lying in your bag, and then come up and then chew it up that much. So here it's completely undisturbed, only you have created a small amount of the cavity. Let's see how Dr. Vasavada explains it very well. So if you have a paper and you have a PC rent, so some amount of the woolen material which is showing here has the vitreous prolapse, and if you try to pull it from down, so it is very well, it goes down and then clearly it settles. So without enlargement of that much of PC rent. But if it is on the other one, you try to pull it, so there is always a chance of enlargement of the PC rent, and most of the vitreous which is in bulk, it is coming out. He is showing it in a nice way with high resolution camera. So here you can see it. So you can see the PC rent here. Yes. So if you see slowly from this is from the limbal approach, and slowly the enlargement of, if you can make it out, the enlargement of the PC rent is occurring here. So yes, even after this also, whenever you are doing a vitrectomy, whether it is anterior approach, anterior limbal approach or pars plana,
after that, it is a mandatory, or it is a better to do always a kind of an indirect ophthalmoscopy to look for the peripheral, whether any kind of a break has occurred due to this pull of the vitreous. And the standard guideline from AO is all phacosurgeons should know the 23 gauge vitrectomy, anterior vitrectomy as well. And whenever you have enjoy the day. Thank you.
Thank you, sir. I just have one question, sir. Definitely doing the vitrectomy from the pars plana route, if you do the vitrectomy, definitely you can cut off the stalk very well, and then the prolapse of the vitreous will stop. But my main question is, how many of the anterior segment surgeons are willing to make a pars plana port? We are retina surgeons, we are very much comfortable.
In the morning session itself, it is decided that they will give intravitreal injection. So if they can give intravitreal injection, why not to put 23 gauge? 27 gauge, 30 gauge, if we can put, then 23 gauge also can
No,
be
one issue which I want to point out is most of these cases are under topical anesthesia, so that becomes a issue. Putting it 23 gauge with
you can always, you can give a perivalvar block in that way.
But
subtil and perivalvar, whatever you can.
So any comment from the audience? From the chair panel? Yes.
No anti-segment surgeons are there?
Surgeons are there.
Okay. No, with all due respect, when the nucleus is dropping, first thing I tell our people, our anti-segment, because we are a very high volume people, I tell them three things. One is, which is when it is dropping, please allow it to drop for two reasons. One, the patient will be happy, and second thing, you will have the privilege of feeding a VR surgeon.
Yes.
Right? He can pay his bills by doing that, number one. Number two, never use a pilocarpine. There are so many people who use pilocarpine, I don't know for what reason. And third thing is like, never make a second tunnel, because it is a nightmare for us, because they'll be doing a temporal phaco. And to retrieve the nucleus, they would have made a nice SICS superiorly. So there will be opening everywhere actually.
Everywhere, yeah.
So it's very difficult for us to manage. So don't do the second tunnel. Allow it to drop, suture, and if possible use Tricart and remove all the vitreous.
So basically, when we get patients, sometimes we see that the wound is not sutured. The wound should be sutured. The anterior segment should be made clear of the vitreous, because sometimes the patient comes to us after 6 hours, 7 hours. By the time the cornea becomes totally edematous. So I think properly the anterior segment should be managed properly and then sent to the retina surgeon.
Very
about
true.
lens, sir has already mentioned about what to do about the lens.
Also not put air. I know it's totally criminal to put air in a phakic patient, but sometimes I do get patients who have air in the AC referred the next day. So, and many times their pressure is very high and the cornea is very steamy, so the surgery has to be delayed because of that. So air, we all know as postgraduates also, undergraduates के air नहीं डालना, but some people still put air just to prevent hypotony.
And sometimes we, when we go and inside, the case has directly come to us, some surgeon has not referred, it has directly come. And sometimes we see multiple lenses have been put, they have dropped, after the nucleus, lens has been tried to be put and it has dropped. I think those things should stop. Like when there is a drop, that, like sir said very nicely, let it drop. Then I think we can manage it, and it is a good prognosis. It is a 6/6 prognosis case, we can give 6/6 to the patient actually.
Yes, Rupak, if I may have to add something.
I think
segment surgeon. So as Rupak said, that when it drops, so it becomes a purely vitreoretinal surgery case. Okay, so anterior segment surgeon should not try, however injections you have given. And another thing important, that just giving one injection and doing vitrectomy, what we, the anterior segment surgeons, fail to do is to understand our machine very clearly and how to set the machine. Because when you are doing the vitrectomy in anterior segment PCR cases, supposing there is no nucleus drop, it has happened only when you are clearing the cortex. Then some vitreous has come up in the anterior chambers, and it's your job to clear it up. But you have to know your machine and set it properly. Like, when you are clearing the cortex, you have to say irrigation, aspiration, then cut. And we are cutting the vitreous, then you have to set it like, irrigation, cut and aspiration. But most of us, we are not familiar with this kind of settings in our own machine. We really don't know how to change it. And that makes things even more difficult and enlargement of the break and other things, whether it is anti-segment approach or is the personal approach.
Very true, very true.
And just I want to make a point. I think it's not so important to implant a lens then and there. I think we have to manage the pressure, the stride keratopathy, the inflammation postoperatively, and hand the case over to the PR surgeon, and we can think about the placement of the lens later on, assessing the PC status.
Absolutely. So we will go to our next topic, which is a little bit continuation of this topic. Is Dr. Rupak Roy. He will talk about secondary IOLs.
Thank you, SWB Scientific Committee, for this opportunity. This is a basic presentation. My presentation is not showing. It's IOL techniques when there is no PC support. There are many techniques that are available, and various surgeons are comfortable with various techniques. So there is no right or wrong. Whichever technique is you are comfortable, you should do that. So basically, this is a situation we have when there is a post-cataract complication. There could be subluxated cataracts, or there could be late IOL dislocations. And there are customized techniques for each situation. So I will just, there's a standard SF IOL, and then there is a glued IOL, then there is a Yamenis technique, then there is bag refixation, and now we have a CMT flex IOL, and we have an iris claw lens. So various surgeons are comfortable with various techniques, and each have their own pros and cons. So this is an old video by Dr. Pramod Bhende, which I had. So I'll just share. This is the basic sutured scleral fixed SF IOL, not very old technique. But for the beginners, before you go to other complicated techniques, this technique everybody, I feel, should master, because if you land up in a problem, you can pretty well do this technique. So basically here you make two scleral flaps at 3 o'clock and 9 o'clock, and you pass a needle. This is the railroad technique where you pass the needle to the haptic. There is a hole in the haptic, and you do the same thing from the other side. So one from this side and one from the other side. There are two holes, and you can pass back the needle and take it out from the flap. So we have a 4-point fixation here, and this is a very stable technique and a very well-established technique. But there are problems like suture breakage and all those things. But this is a technique which I think whenever a person is starting a SF IOL, they should learn, because if you have any problem, you can always go back to this technique. This is a video of a Yamenis technique, which is this is one of my cases. So again, the marking is very important in these cases. First, of course, we have to do a vitrectomy. Either you can do a good anterior vitrectomy, or you can do a 3-port core vitrectomy. And here there is no need to make any scleral flaps. The whole thing can be done subconjunctively. So here I am putting a Sensar lens. You can either use a Sensar 3-piece, or there is a Alcon 3-piece also, which is available. Both of the lenses serve the purpose pretty well for this surgery. And you can see it's a foldable lens. I put in the lens. Now this is the 26-gauge needle, which I am negotiating through the conjunctiva directly, and it has to run an oblique course, then go inside the vitreous cavity. And from the other end, you can use a forceps. You can use a forceps to hold that haptic and feed it into this the mouth of the 26 needle. So this leading haptic managing is actually not very difficult. The difficulty lies in when you have to manage the trailing haptic. So you have to nicely feed it inside, and then you can sort of just gently pull out the 26 gauge, and along with that the haptic comes out nicely, and you can just cauterize its tip so that it does not sort of go back. The challenge lies in putting the trailing haptic, because the orientation is little different of this trailing haptic. But this, the good thing about the Sensar lenses are that they are little forgiving, the curvature of the Sensar lenses, so you can just twist them a little bit. So this 26 gauge can be, is very easy. You can just put it out of the globe, and you can just sort of feed this trailing haptic. Now this trailing haptic is the thing where most of the people have little challenge, but the sensor haptic and the Alcon haptic is little flexible. So what you can do really is you can just put it inside, and once it goes inside, you have to make sure it is fully inside. Otherwise, sometimes what happens, it comes out within the eye. Then it becomes very difficult. So just make sure it is fully inside the hub of the needle, and then gently pull it out from the conjunctival side, and you have a very well-centered lens. This is a very simple procedure and very less traumatic procedure. So yes, it works well. Some people do a variation of this. They will make a scleral flap here and just tuck this haptic inside the flap. So this is a Yamanis technique. This is a good technique that can be done. One small problem is sometimes we have seen that small end of this haptic can extrude out of the conjunctiva and cause a chronic irritation. Coming to my, this is another situation where you have no PC support, and there is a complete aniridia also. So this is mostly these are the post-trauma cases. I just wanted to highlight this is a special type of lens that is available, which is known as the aniridia lens, which is basically, this is the aniridia lens. You can have the coverage for the iris. This is basically a standard sutured SFIL. But this is a custom made lens by the Care Group. So you have to pre-order it, and the lens is pretty large. So if you plan to do it, please keep, and it is little fragile. So keep 2 copies of it or 2 numbers of it, because one might break. So the last video that I want to share is, this is a lens which is popularized by one of my friend Dr. Nivian. And this surgery is actually done by Dr. Vikramjit. This is a CMT flex lens, which is another very good option, as recently been described. So this is a case of aphakia. So first the marking is done nicely, and you have to make flaps similar to SFIL flap. You can make 1.5 millimeter entry with a 23 gauge forceps. And yeah, but the beauty of this procedure is, now this is the lens that they are implanting through a foldable inserter. The lens is the haptics, the end of the lens is actually T-shaped. So you can see they are holding this with a forceps, and you gently pull it out from the other side. The problem with the normal sensor lenses is you have to make a groove and then put the haptic inside the groove. But here the design of the lens is such that this T-shaped end nicely fits snugly in this end, and it will not go back inside the globe. And for the other side, you have to just pull it with a forceps. You can go through a side port and just pull it with a forceps, and then the trick, as they say, I have not done this procedure, but as what Vikram and Nivian both has told me, that you have to hold gently at the T and then grasp it. This process is important, otherwise it can break. Then you gently pull it out, and of course when it is out, you have a very well-centered lens. And the good thing is that this T does not allow this thing to go back. So it looks like a very elegant procedure. I have not tried it, but looks really very nice. So yeah, you have a very nicely centered pupil and a well-centered lens. So in a nutshell, there are many secondary IOL techniques. So each surgeon has to find out which techniques works best for them. I think that is all, Sangeeta.
Thank you, sir. So any comment from the panel? Yes, Doctor.
Yeah. So as I told you, Shaptoshi, I really have not done, but Nivian has been doing this for last 2 to 3 years, and he has got excellent results. And now this video I have taken from Vikramjit. Vikramjit is also doing it for, so they have really not reported any, this issue they have not reported.
So one thing, sir,
I have personally not used iris claw lens, but as I told in the beginning also, the iris claw lens is also an excellent lens.
Yeah, I am using, I think Dr. Maiti is also using a lot.
But one
iris
thing
claw
is,
lenses you are using.
Iris claw, yeah, I think Anandada is using. But taking out an iris claw lens is a nightmare. Recently I had to do one, and it almost, you can take out almost the whole iris comes out with it.
So one thing, Dr. Roy, there are many anti-segment surgeons here who do these secondary IOLs like SFIL or iris claw. So how much vitrectomy you advise them to do? Because we can do a core vitrectomy.
Yeah.
We can do.
So I think a good anterior vitrectomy is must. I think Dr. Sinha had done a paper on that long back, complete vitrectomy versus anterior vitrectomy for SFILs. And I think he did not find any difference. So I think if you do a good anterior vitrectomy and you really need not, see, ideal is if you do a complete vitrectomy, but for an anterior segment surgeon, sometimes either it is not possible because the instrumentation is not there, facilities are not there. So in a way, if you can do a good anterior vitrectomy, clear all the vitreous, then I think it is good.
You have to see the periphery for any holes. Peripheral holes.
The on table or key could dekh sir.
Indirect
on table there is a rent or what very
that has to be seen.
Obviously post-op I think.
So I'll two quick points for everybody, not just anti-segment surgeon. If you've had any PC rent, any procedure done more, my request to all anti-segment surgeons: patient is yours, keep the patient with you if you've managed it well. But keep seeing the periphery with the indirect for at least every month for the next 6 months. Then having small horseshoe tears with the vitreous loss, and those lead to RD. Patient never blames you, they come to us. Because the surgery went off, you gave good results. Keshav, 1 second, yeah. I will take Keshav's bet in this. A simple, good ACIOL, I think also works fine. You don't need all these fancy things. If you're good at your ACIOL, put in a good ACIOL. Just as simple.
Just I wanted to ask, suppose there is a very small rent, anterior segment surgeon, and there is a rent. What is the role of mechanical, means non-vitrectomy, means just a mechanical reposition of vitreous, and is it recommended?
No, I don't think, sir, it is recommended. Because see, whenever vitreous is attached to anterior, you are able to see the vitreous, but you don't know behind which all structures it is got attached to. So whenever you are doing a vitrectomy, you are cutting it, so you are not really pulling it. But whenever you manipulate that with an instrument like a spatula or a Vannas scissor, there is a traction on the vitreous, and the vitreous is pulling somewhere in the periphery. So you don't know what kind of damage you are doing. So okay. I think it is not recommended. Either you cut it or you just leave it.
I have very limited experience. I have never
right,
had any experience
right,
of referring anybody with a drop, but just asked.
Sir, in modified EMNA, what we have been doing is that at 3 and 9 o'clock, instead of using the 26 gauge needle, just put 2 trocar cannulas and 25 gauge, and take the forceps, hold this haptic, and take out this cannula first. And then you take out the haptic. So it will easily come. And instead of 20 gauge, we can do this. And in CMT flex, one of the crux is that instead of with MVR, the incision which we have to make is, it should not be parallel to the limbus. Otherwise, that T, it will slide inside. So it has to be perpendicular to the limbus.
So any particular forceps?
The same forceps.
Sir, management of haptic exposure. Like when I was doing flap technique, now I have moved back to a modified Gabus technique. So when I was doing flap technique, say out of 50 cases, I used to have say 2 haptic exposures or 3 haptic exposures. So my plan of action was one, trimming the haptic once the lens has stabilized. But like over the last 5 years, when I was doing flap technique, I had to get 2 patch grafts done over the haptic by another surgeon. So what is your plan of action for a haptic exposure?
I also think so. Some of the cases I have trimmed, but sometimes some needs some sort of suturing, some grafting over it.
With it, but now once I switched to the Gabor technique, like the traditional old Gabor technique, haptic exposure has almost reduced to 0, sir.
So that is inside the flap, right?
Inside a flap, completely inside.
That is, see, Yamene has this problem also of this exposure.
When you have done
blue dial also,
just a minute.
Yeah.
The only thing is the cost maybe.
But you mean you glue the flap, right?
Yes, glue the flap.
Yeah. Yeah, so that is okay.
For the exposure of the haptic, did you find any problems?
Yeah, so A, so there is a risk of infection, and B, sometimes they cause a chronic irritation to the patients. Typically the patients complain that always there is some watering, some redness, they're not happy with it.
Rupak,
when you've done a good IO before the cataract surgery, and when there is a rent, and when you're doing anti-vitrectomy, then why is pilocarpine not indicated? Intracameral pilocarpine.
Sorry, sir, I did not get your question.
No, I've done a good IO before
Yes,
the cataract surgery. Done the cataract surgery. During the surgery, there was a rent. They did anti-vitrectomy. But why intracameral pilocarpine is not indicated? Yes.
No, the question is other way.
If you have a nucleus
no,
drop,
the question is
not drop.
No, otherwise also my question for you is why pilocarpine? You are asking us why pilocarpine. My question is why pilocarpine? Because it's not going to serve the purpose. One, the pupil is going to be small, you cannot do any indirect, any examination X-ray. Second thing, it's going to increase inflammation. Third thing, no way the pilocarpine can take the vitreous back into the cavity. It is impossible. So there is no point in using pilocarpine. Should not be used. Better.
But it does help to demarcate small vitreous strands. And you can pinpoint your cursor. After putting the lens, if you are sure that the lens is in position, it will not get dislodged. And if you use pilocarpine, if there is a picking up the pupil, you know that there is a vitreous strand there. I know you can do it that with triamcinolone as well.
Yeah, that is a better option than pilocarpine.
No, but I think what some anterior segment surgeons do is they will put the lens and do vitrectomy, put the lens, and then they will put the pilo to, as what Shugatada is telling, to check whether there are any strands left, because pilo the people will construct and give a round shape. If they get it, they understand the vitrectomy is complete. But what sir is trying to tell is do a triamcinolone, but some pilo can be given. I think there is no contraindication.
Again,
the
inflammation part
is there any harm in intracameral this moxifloxacin going into the vitreous cavity?
No.
Sir, putting
actually moxifloxacin, the recommended dose is 0.6, not 0.5. We are injecting 0.5, actually it's 0.6. And what is recommended in case of PC rentit is 0.75. We have to increase the dose whenever there is a PCR. So when there is a PCR, you increase the dose to 0.75.
And when you mean corneal incision, you are suturing, would you allow us to suture the side ports also?
Depends. If it's not leaking, no problem.
Sir, do you advocate putting air in AC to push back the vitreous?
No.
No way.
So
triamcinolone you can use without any fear, because 1 or 2 drops going into the vitreous cavity is not going to cause any problem. In fact, it might prevent even CME formation also. But it identifies every single strand of vitreous, and it's very helpful for us to cut all the vitreous. But the basic difference between anti-segment surgeon and posterior segment surgeon is your vitreous maximum cut rate will be 2,500 or so. And that is a child play for us actually. We operate at 10,000 or 16,000. So you use the maximum cutting and fairly decent vacuum, maybe 200 is fine for. But use the maximum cutting,
I think,
not.
Sir, now the Centurion has, I think, 5,000 cut rates.
5,000, I think.
Centurion has 5,000 cut rates.
So what will be your advice for the anterior segment? If there is a capsular support, to put the 3-piece and refer the patient to the VR surgeon for nucleus drop, or just leave it a phakic and do this.
Two things, sir. One is the size, depending upon the lens hardness. If the lens is grade 4, grade 5, grade 6, then you think of not putting the IOL. Second thing, you can place IOL, no issues, but see to that it's also not dropping. If you are sure that it's not going to drop, there is no harm in placing the lens and then sending. And see, nucleus drop is not a negligence. It is a complication. Hiding the nucleus drop is becoming a negligence. So it is a complication. And second thing, it is not a emergency. See, when we compare within 1 week and later on also, the outcome is the same. So all we have to do is maintaining the IOP, and second thing is, controlling the inflammation. So it's not an emergency, no need to panic. You can refer after 2-3 days also, nothing will happen.
One very important thing is not to have any...
I just want to highlight. So sometimes we have seen cases that the patient has a nucleus drop and the anterior segment surgeon has put in a lens. Now the problem is the lens the surgeon has put, and the lens has also got subluxated. Now the patient comes back to a VR surgeon and you cannot take out that lens, because that surgeon would have told the patient that I put the lens, the VR surgeon will lay the nucleus out. Now you suddenly have the patient with the lens which is subluxated. So, I mean, only we should put a lens when we're absolutely sure that the sulcus is good and the lens is well centered. If you're not able to do that, then better to send the patient telling that the lens and the IOL insertion and the nucleus draw will be managed at the same time.
A single piece lens should not be put in the sulcus. Many
Multi-piece
people send
always.
multi-piece lens has to be sent.
And one very important point is one should be very careful that there should be no vitreous weaking from the side ports, because that will invariably end up in end-off. So that is very, very important. No vitreous in the side ports or in AC.
Another point which I wanted to make is that whenever you're using IVTA, that should be mentioned to us, because sometimes when you are manipulated a lot in the post-op period, the cornea will be hazy, and we'll miss that as an inflammation or as a endophthalmitis. So the differentiation of an hypopion from an IVTA crystal also becomes very difficult at that point of time.
We should go to the next topic now. So I would like to request Dr. Naresh Babu to please present his cases. Again, really one of the most challenging cases for vitreoretina surgeons, IOFP.
Okay, so when it is getting, thank you Dr. Rupak for the invitation. And they said actually it is going to be a session for the residents, but I think most of the residents are in their residences, I think. Yeah.
I think you have started getting the flavor of Dr. Naresh Babu. Okay, so this is how he skill, knowledge, and the weakness. So that's how is a combination of Dr. Naresh Babu. He's a senior vitreoretinal surgeon at Arvind Eye Hospital, Madurai, and he has the vast experience of teaching as well as the clinical work, academic work, publishing. So. Dr. Naresh is podium for you.
Yeah, it's getting loaded. Sorry for the delay.
The moment sir is getting ready, Dr. Rupak Roy, I think he left. So he said one thing, that if the lens is put and there is a nucleus drop, then we are in soup that what to do with the lens. What is the opinion? I think we should tell the patient that the lens is not stable and we can take out the lens and put a more stable lens. I don't know, somebody from the audience, if you can come, if you can.
Check. Fine? Okay. Right. Once again, thanks Dr. Rupak for the invitation. And I could see a lot of my colleagues here actually. Happy to see them. And as usual, who is going to financially sponsor this talk of a trauma? So there is no financial disclosure to make. So open globe injury is one of the worst thing to happen actually. If the injury is very bad, any residents here? Nobody? Okay. Any anti-segment? Yeah. So what will you do actually if any bad case comes to you with the open globe injury? Okay, so no, I will not do that. I will send it to my competitor actually. Okay, let the headache be his problem, because most of the time the outcome is going to be bad. So do a first aid and send it to your competitor. Okay. So that is his headache after that. Okay, so better not to approach in case if you don't have the adequate facility for managing a open globe injury. And most of the time it is the teenagers and males are more often affected in this. And India has got one of the highest rate of DALI, right? That is, a disability associated yeah. So we have one of the highest, and that is basically because we don't care about anything. So we all suffer from, all of us, including everyone in this hall, we all suffer from a syndrome that is called it will not happen to me syndrome, right? So when we go in a car, we will never wear the seat belt because it will not happen to me, no helmet because it will not happen to me, and no protective glasses when they are doing the drilling work, because they are very confident that it will not happen to them, and most of the time they end up in intraocular foreign body. And basically when we are treating open globe injury, we have got three windows. The first window is an acute window where we have to preserve the eyeball and prevent the infection, and the other two windows basically will be dealing with the sequelae. In the first window, what has to be done is no infection should happen, and in fact, the second and third window needs the expertise of a VR surgeon. Okay, this is what we are. So before we start the ocular examination of the patient, we have to ensure the systemic stability. Fortunately, we are all in the specialized eye hospital. We don't get this the road traffic injury or the blast injury. Most of these cases come to us after the stabilization of the systemic condition. But if you are in a general setup when there is a blast injury or something like that, we have to first ensure the systemic stability because life is more important. And second thing is meticulous history taking is very, very important. I'll show you why it is important. Documentation and examination, because every case is, even though it's an accidental foreign body, is going to be a medical legal case, and we have faced the brunt of that. That also I'll tell you. And we have to evaluate the periocular structures, including the orbital wall, lid, everything, injection TT and shield for protection. And most of these cases, however young or old the patient may be, it is better to take open globe injury or the foreign bodies. If they are small, it's fine. Under general anesthesia, it's preferable, because if the procedure gets prolonged, it's very difficult, because along with the local anesthesia, we'll have to start the vocal anesthesia also. So this I'll just skip for want of time. And see, the occult sign of injury should always be noted. So this is a case, he came with the history of injury, but there was a very subtle subconjunctival hemorrhage, and we had a similar case. Believe me, there was a lid tear. A person was seen as noted the lid tear, small lid tear, subconjunctival hemorrhage, but he forgot to take an X-ray. Actually, the patient went in for endophthalmitis, went to the court, and I think we have to pay the penalty for that. So any subtle sign, look for it. And in this case, even though it's a very small subconjunctival hemorrhage, when we went inside and we could see a foreign body lying inside the eye, it's the same case. So they are not two different cases, same case. And we have to classify the injury basically just to tell the, grade the injury to tell the prognosis. And especially in all these trauma cases, counseling is very, very, very important before you take up the case for the surgery. And usually we do the counseling in groups actually. If there are 3-4 people, don't bother actually. It will be like a crowd. It will be like a public meeting. Don't bother, call them and explain them, because first uncle will come, then aunt will come. 2 days later, the other relatives will come. So better to make them all sit and tell the prognosis. And we are telling the prognosis, be brutal, right? Don't give any false hope. And we always tell that patient may require at least 3-4 surgeries, even if it's a small foreign body, because we don't know. Suddenly, if the patient develops RD after a foreign body removal, then they might say that you have not told. So always counsel about multiple surgeries in these cases, and be frank about the prognosis. We are not going to achieve anything by telling false prognosis, and the chance of thysis should always be explained. Imaging should be done, because as I told, all foreign bodies are potential MLC cases, and we have to do that. And this I'll skip, I think, most of the things. So we'll just go to the localization. History is very, very important, as I told earlier, because history can reveal you the nature of the foreign body and what exactly happened. So this one patient came to us. He had multiple pins in the, eyes. So when we asked, he said he was drugged by some local gang, and they put the needle inside the eye. But somehow I could not believe that. So he had an old X-ray, which was taken elsewhere some 3-4 months ago. This is the number of pins in the eye. And actually, when we did the X-ray in our place, there were more than 60 pins. And actually, then we went for the CT scan. So this is a 3D construction of multiple pins. So here, I was very sure that this is not done by anybody, and this is a case of a self-inflicting injury. And this was before taking up, sent to a psychiatrist. This guy was given a counseling. So he told that why he has done that. These are all the hypodermic needle used by his father for insulin, taking insulin. So this guy has put the needle inside the eye because he was so depressed that he didn't get married. I said, Bhagar, you are lucky. If you would have got married, you would have had pins in both the eyes. Okay. At least one of your eyes is saved. So we took him up for surgery. We removed the pins, but he couldn't get the vision in the eye, but he is still in our follow-up. The most important way of localizing a foreign body is direct visualization. As soon as the patient comes, dilate, look for the foreign body. That is the best way. And X-ray is very, very important because it's medico-legally important, and we have to do an X-ray PA view, and most of the large foreign bodies can be picked up with the X-ray. But sometimes if the X-ray and if you don't have the facility for the CT, then we can go for the limbal ring. Flaring-gas ring can be used. So this is a case where there is a ring, and we can assess whether the foreign body is there inside the eye or outside or in the coats. It's a very beautiful technique. But in one of these cases, it was very useful. So this man was hammering a bulrus. The bulrus entered his eye. Then we took the X-ray. So with the ring actually. So it was not fitting into any of the ring. So it was way beyond. Then we went in for CT scan, it was in the frontal lobe of the brain. Fortunately, we have not taken this case for surgery. So when you are going in for surgery, be sure where your foreign body is. And doing an ultrasound is very, very useful, but we have to be gentle not to expel the content, because this tells us the collateral damage, how much of vitreous is having vitreous hemorrhage or any retinal detachment or any scleral tear, the position of the lens, everything. So ultrasound is a wonderful tool, and if you master the technique of localizing the foreign body in ultrasound, that means you have mastered the ultrasound. So it's a bit difficult. Okay, so CT scan is very important because it's very, very sensitive and very nice in localizing the exact location of the foreign body. And when you are doing an MRI scan, be careful that it is not a metallic, because in metallic foreign body, the movement of the foreign body can be up to 7 to 8 millimeters in the suprachoroidal space, or it may be even 10 millimeters in the vitreous cavity. So during that entire spiral MRI, you would have completely churned out the vitreous. All you have to do is just go and aspirate it. So don't do that, unless otherwise you are very sure that it's not a metallic foreign body, but it is very useful in plastics or vegetable materials. Okay, and ERG in the last window, it's very, very important. So when you have a sidrosis like this, do an ERG. And the ERG, if the ERG is flat, will you take up the case for surgery or not? The question is, I will take up, provided I will do EOG also. In the presence of good EOG, and if the ERG is extinguished, still it can be taken. But if both EOG and ERG are extinguished, then the outcome is usually poor. So having a sidrosis is not a contraindication, but do an ERG, and in fact we have found that in a series of 17 cases when the foreign body was removed, there was the reappearance of the waves in ERG in most of these cases. But there will be a severe inflammation, do the surgery under the, the foreign body, steroid. So the main management objective is first to establish the integrity of the eyeball, then you have to prevent the infection, very, very important. And if the, the environment is, very nasty and the foreign body center, invariably they go for a very bad endophthalmitis, usually with the bacillus series. Then you remove the foreign body, maintain the clear media in case if there is an RD, manage it. IOP control is very important. And of course, we have to take care of the fellow eye for sympathetic opening just 2 minutes. Okay. As far as the timing of surgery is concerned, all reactive foreign body has to be removed. Inert foreign body I have seen is the gold. Only one case of golden eye I have seen. But we don't know the purity of the gold. If it is 24 karat or 22 karat, it's fine. If the goldsmith has played extra, and if he had put extra copper in that, instead of gold, it might be a copper foreign body leading to charcosis. We have to be very careful about that. Nature and the location of the foreign body also, determines. And you have to have a good armamentarium. See, these are some of the foreign bodies which we have removed actually. So not every 23 gauge or 25 gauge will fit into, we have to have a good armamentarium. One is this beautiful intraocular magnet, rare earth magnet. Almost every other magnetic substance can be picked up with this. The other one is a good forceps. And this is the one, Bapai's forceps, a very nice modification of Darmia's basket. And the other one is this extraocular magnet. This is in fact older than me. Actually, there are two old useful things in our hospital. One is Dr. P. Nambarmal Sami, and the other one is this one actually. These are the two excellent working things in our hospital. Okay, this belongs to our chairman, Dr. P.N.'s days. So this can pick any foreign body actually. Okay, so I think, yeah. Yes. So, okay, I'll just go to one or two videos and then we'll stop it because most of them will be routine. No, this is a 3D. Yeah. So this is a small foreign body but with cataract actually. Usually we go for lensectomy in these cases because just to spare the capsule and we can put the lens in the sulcus. And these are the days when we are not using the Oroflex, we were using the rigid lenses. You can see the foreign body nicely lying, but away from the fovea. So it's very good actually in these cases, the prognosis is. Usually we induce PVD. So once, if you induce PVD, most of the time the foreign body comes out with that. Or if it is not coming out, we can use a 23 or 25 gauge, what you call the MBR, to tease the foreign body out. And then we can remove it with the rare earth magnet. And when it comes to the sclera, we can, okay, this is what I was telling, just tease it with the 23 gauge MBR, it just comes out of the surface. Then we use this intraocular rare earth magnet, which I was talking about. Bring it to the sclera, but the alignment is very important. It should not be, it should be what you call perpendicular to the sclera, never parallel to the sclera. Once it is done, this is the rare earth magnet, the extraocular electromagnet, which I said, which is very good. Okay, so this was a very nice case. A child was playing with this chain. When she was rolling like this, one end of this, what you call the chain, went and hit her father's, what you call, eye. And this was sort of a brass, so there was severe inflammation in this case, you can find out. So what happened is, but fortunately the case did well, some 660 was the outcome. This is the other end of the connector of the chain. So we somehow removed it with the, what you call, vectis. But in this case, actually, the only person who was happy was the child, because she got back the connector for the chain. So the father didn't get the vision, and we were also not happy with this. So sometimes it happens. Okay, so this is the only good thing which happened with that foreign body removal. I don't know what is this case. Yeah. So this is another case of a long foreign body. But this is nothing great actually. See, the only thing I want to highlight is when you are taking the foreign body, you just align in such a way that it is perpendicular to the sclera, because if it is parallel, it might get stuck. And 4 millimeter is my threshold for taking it through the sclera. If it is more than 4 millimeter, most of the time we go for the, what you call, through the, next. I'll just go to the next. So more than 4 millimeter, usually it is a transscleral route. I think this is another case of a foreign body which has gone and hit one of the largest, foreign body. I think same, because of the carelessness of the people, you can find a nice high-end foreign bodies. It is literally like Eiffel Tower on the optic nerve head, if you could find out. So it's standing on the, where is it? So as I told, my threshold is only 4 millimeter. Beyond that, I don't go for. So this case, actually, it was quite a large foreign body. So we made a, what do you call this thing? And usually 20 gauge instruments which are kept in our museum are very useful for foreign body cases, because 23 or 25 are of no use for these cases. You can find out, this is from the disc. We just pulled it out. And as I told, the only mistake I have done is making a scleral tunnel. A clear corneal usually brings it much easier in these cases. So this is one of the large foreign bodies. It was there. So we get a variety of foreign body, all because of the carelessness of our people, not because of anything. So I'll just, for want of time, I'll just skip it. Prophylactic buccal, we don't do it anymore. Again, prophylactic antibiotic, systemic, they say it's not making much difference. So basically the prognosis depends on where the foreign body is and its size and its inertness and the infection along with that. Okay. The most important thing is we have to take care of the fellow eye, because the incidence can be 0.1 to 1%. I have not seen any this thing. In fact, I have seen endophthalmitis, sympathetic endophthalmitis happening in a simple vitrectomy, but so far in foreign bodies I have never seen. But still we have to be very careful, because that will be the only seeing eye. And so always take care of the fellow eye when we are doing the foreign body. And as I told, counseling is very important. And with this, I would like to thank once again Dr. Rupak for giving me the opportunity, and thank you. Any questions?
Thank you, sir.
Yes.
Dr. Naresh,
yes, sir.
I'm having one question, and that is my dilemma actually. I removed a lot of metallic foreign bodies. Okay, in one case, I have done lensectomy, then vitrectomy. I removed a hard metallic foreign body and done endolaser and finally put silicone oil. The very next day, I have seen that I missed double perforation. Means it is coming out through the sclera, and now it is very close to optic nerve head. In this situation, what will you do?
No, we'll have to wait for, if you can suture the exit wound.
It is very posterior.
That's what I'm saying. If we can suture, we suture it. Otherwise, what I personally do is, actually one of the cases I want to show that video, I couldn't do that. Same thing, I have done a foolish thing by going inside the eye without realizing, without knowing the exact location of the foreign body. It was double perforation. The foreign body was behind. Fortunately, I could bridle and retrieve the foreign body from behind. In these cases, we can wait for 2 weeks because naturally it's going to heal the wound. And after that, we can take up the case for the foreign body removal.
But in my case, the silicone oil is coming through orbit. Means.
Yeah, that's what I am saying. We shouldn't have taken. We could have waited for 2 weeks. Now maybe the other option is we can remove the silicone oil, wait for some time for the wound, external wound to heal, and then we can go inside.
Sir, my question is how deep should we dig? How deep should we dig to retrieve a foreign body? I had a case where there were 2 foreign bodies confirmed by CT. One I could see on IO. The second foreign body was definitely deeper. It had passed to the choroid and probably going past the sclera.
Right.
And in that case, while I was doing the vitrectomy, I realized the findings were correct. I removed the first foreign body. Second foreign body, if I had attempted to remove, probably I would have landed with a large subretinal bleed with destruction of vision. And in this case, if I left that foreign body, the patient would land with 6/600%. Right. So I, at that point, called the patient's relative, explained the situation, and left that foreign body. I followed that up for now 3 years. The patient is 6/6. But what is how deep should we be digging?
Yeah, 2 things. One is, what I usually do is we go for the vitrectomy after bridling the muscle. And what I do is I usually remove all the fluid from inside the eye so that the eyeball literally collapses. Then I use this magnet because I am not going to fish with any instrument. Magnet, the rare earth magnet. So if the foreign body is felt, it's fine. If it's not there, better to leave it, because if it's outside the coat, it's not going to cause any problem.
Yes, sir.
Better leave it.
So what is your take on
Yeah. Yes. So one thing is you can use this Bapai's forceps, number 1. But if a glass foreign body comes to me, I'll just take it, place it somewhere in the periphery. If possible, make a small retinal flap, bury it under the retina, because we do that for CNVM plaques, submacular surgery. No, I am just saying, just leave it inside the eye and close it, because glass is inert. And second thing, by removing the foreign body, the collateral damage in these cases will be more and will be losing the eye. By leaving the foreign body glass inside the eye, nothing is going to happen. Maybe if you want to secure it, maybe peripherally we can make a small retinectomy, bury the foreign body under that. We have done that. Just laser it and leave it. It will be under the retina and somewhere in the periphery without any issue. But usually, if the surface is irregular and the foreign body is large, 2 things I don't touch is, one is mica, the other one is glass. Because mica is also very, very difficult to remove. So glass is inert. I think we can just leave it better.
So what is your advice about this timing of the surgery, sir? Because many people say that if you wait for 2-3 weeks, the cornea gets cleared, the vitreous gets loosened up, so it is easier to do. So what are the indications where you should do an immediate surgery and where we can wait for some time?
But the only concern for me is by waiting for 3 weeks, infection should not happen. If the patient gets the infection, then it's very difficult.
Right.
So my choice will be as early as possible.
Okay.
As early as possible.
Okay. Thank you, sir.
Thank you.
So if we have...
Yes, sir.
If there is a sclerocorneal tear and there is no facilities for GA, can you do it under LA?
Yes, sir, we can do it actually. We can do it. But why GA means you can take your own time, relax. The patient is also peaceful, you are also peaceful. Because many times, if you are going to give any retrobulbar, all the content will come out. Peribulbar also very difficult. If it is under GA, you are not going to touch the eyeball, so it's safer. That's the reason, because we don't know where all the tear is. And especially in case of blast injury, when there are multiple foreign body, only way is GA. So most of the trauma we take under GA.
it's a fresh injury. Do you advocate people to give topical antibiotics?
Yes, sir. In fact, if you are referring a case, I'll even say if it's an open globe injury, if it's not very large, if you find a foreign body inside, if you don't have the facility, we can go for intravitreal injection and then refer also.
Now, suppose patient comes in the morning and you want to take it up in the evening.
Yeah.
So in that hours,
Yes,
do you
yes.
advise?
Yes, yes.
But in the olden days, they used to say if you advise topical and the external organisms can get into the
No,
eye.
but you said it's olden days actually.
Right.
So now we
Right, so
don't.
now it's changed. Oh,
so we all have become modern now.
So we can we can have always a part 2 of foreign body. So we will request Dr. Naresh, please be here to be, put a big round of applause for Dr. Naresh, and then I'll request our president, Dr. R.C. Paul, to present the bouquet and memento to Dr. Naresh, please. And this is our pleasure to have you here, sir. Yeah, no, it is not over. That is the beginning. So this is what we call is a dokra, is made up of brass, and this is Goddess Durga's idol here. Thank you. Yes. And this is the sweet of Bengal. So you cannot avoid sweet without that. I know that you may not be that much of fond of, but yes, this is you should carry a sweet memory from here. Thank you, Dr. Naresh. Yeah, we'll call our next presenter, Dr. Debashish Boiragi, who does not need any introduction as well. So this is another part of traumatic endophthalmitis. So hopefully you should not get traumatized by the end of this.
Definitely trauma to the surgeon.
Thank you, Rupak. Good afternoon, everybody. At the outset, I'd like to remember my teacher, Dr. P.K. Chatterjee sir. Today is the 7th death anniversary of Dr. P.K. Chatterjee. He always insisted for thorough eye examination. I'll be talking about the traumatic endophthalmitis challenging cases. My first case, a 40-year-old male presented with right eye blurring of vision since 1 week. He had history of blunt trauma 1 month ago. He was diagnosed as a case of vitreous hemorrhage and was on conservative management. USG has been done earlier, which showed vitreous debris with membrane formation. His best corrective visual acuity was counting finger 3 feet, PR was accurate. Slit lamp examination revealed moderate AC reaction with early process of capsular cataract, and there was a large retrolental exudative mass with tiny vascular network overlying it. Fundus was not visible, and history was retaken. And that time he revealed that something fell in the eye while working with chisel and hammer. He went to local ophthalmologist who removed some clot from the eye, which the patient thought of the foreign body, and careful re-examination did not reveal any external eye injury. Imaging was done, both X-ray and MRI scan showed the presence of metallic foreign body. Patient was taken up for surgery, vitrectomy was done, foreign body was removed, and we have found a large tear D with severe membrane formation. So I had to do retinectomy to reattach the retina, and this is the foreign body. And 1 month post-op showed attached retina with best corrective visual acuity of 636. This is case number 2. This 31-year-old male presented with blurring of vision. He had a history of trauma while working in a factory. And on examination, I could see dense vitritis, and I could found one shiny object lying over the retina. I thought of intraocular foreign body, and X-ray also showed the presence of foreign body. Patient was taken up for surgery, and it took 3 hours time, but I couldn't find any foreign body. It was a nightmare for me, and post-operatively the CT scan showed the foreign body actually hanging from the posterior wall of the globe. So the learning is I should have done this CT scan before taking up for surgery. And in the first case, the meticulous history taking is very, very important, what Dr. Naresh Babu has already insisted, and you should have a strong suspicion of intraocular foreign body in any case of mechanical injuries to the eye. So postoperative endophthalmitis comprises almost 1/4 of all endophthalmitis cases, and the incidence actually doubles in presence of a retained intraocular foreign body. It is more common in young individual. The risk factors associated with endophthalmitis are retained intraocular foreign body, mainly with non-metallic foreign bodies, delay in wound closure of more than 24 hours, injury in a rural setting, and in presence of ruptured lens capsule. These are the indications for early intervention, what you have asked earlier. And unlike post-operative endophthalmitis, here we have higher incidence of bacillus species, but most common organism is Staphylococcus epidermidis. And this is a case of foreign body. Lying into the antechamber. It is associated with hypopyon. The foreign body was separated from the adhesion and was removed using foreign body holding forceps. Care was taken not to make an injury to the lens. Thorough antechamber wash was given, and intracameral antibiotic was given. Patient is doing very well. My second case is not so fortunate. This 23-year-old lady sustained an injury with a thorn of a date palm, and here you can see interlenticular abscess with presence of foreign body within the lens. This part is a little tricky because I was not sure about the integrity of the capsule, so I was very careful here. Lens aspiration was done. Fortunately, the posterior capsule was intact, and the foreign body was seen within the bag. It was removed using foreign body holding forceps. Exudates were removed from the bag, and a thorough wash was given. Intraocular lens was implanted inside the bag. And vitrectomy was continued, and we have found TRD with a band extending up to the posterior pole. Base dissection was done. Laser was done around the fibrous band. Intravitreal injection of antibiotic was given, followed by silicone oil injection. And this patient achieved 6/9 vision following surgery, and she is maintaining that even after removal of the oil. And this is a case of traumatic cataract with endophthalmitis with retained intraocular foreign body. Here we can see the presence of large capsular tear, posterior capsular tear. Foreign body was localized, lying on the aura. Attempt was made to remove the exudates as much as possible without creating any iatrogenic trauma to the retina. Vitreous adhesion around the foreign body was released, and foreign body again was removed using foreign body holding forceps. Since we had a large tear in the posterior capsule, I decided to take it out through the antechamber, through the limbal wound, using handshake technique. Base dissection was done, periphery was checked to rule out any iatrogenic break. Intravitreal injection intraocular lens was implanted, 3-piece hydrophobic IOL over the capsular rim. Intravitreal injection of antibiotic was given, followed by fluid exchange. This patient achieved 6/12 vision. In conclusion, post-traumatic endophthalmitis is a devastating complication of open globe injury. Primary repair within 24 hours and prophylactic systemic intravitreal and topical antibiotics can prevent endophthalmitis. Early vitrectomy in high-risk cases and removal of retained intraocular foreign body can salvage eye and vision. Protective measures and increasing awareness among young individuals can prevent these devastating complications. Thank you very much for your patience hearing.
Thank you, sir. Any comment from the panel, from the chair?
I just wanted to share experience of one case. Like Dr. Bairagi said that after extensive search, he could not locate the foreign body. Same kind of scenario I was in. And then I noticed that in the inferior near the aura, there was a small area of elevation and it looked like kind of a cocoon where I suspected that this could be the location of the foreign body. So with a MVR knife, I cut out the cocoon and it was, the foreign body was buried inside. Now if you look back into the history, it all started that the young boy was a bystander. So some iron cutting was done. Was being done in a factory and he just felt that something had hit the eye. There was no opening of anything, no signs of any external injury. There was just a bit of vitritis, just a bit of uveitis, and it was being treated by topical antibiotics, steroids and all that. Finally, with detailed history taking, like Dr. Naresh Babu said, we could think that there could be a foreign body and finally it could be retrieved from that cocoon-like structure inside the area of pars plana, and all the problems were solved later on. Thank you.
Yeah, can I make 2 quick points? One, for those if you're looking at endophthalmitis, while doing vitrectomy, take a sample, send it for cytology examination. I think it's important. A lot of patients with fungus. Dr. Naresh Babu, your opinion on traumatic end of putting in an IOL initially itself with oil?
Usually we don't, sir. We go for oil, but not for IOL in the first instance.
Sir, protocol for managing incarcerated retina, because with a thorn injury, usually you have an incarcerated retina. It can be of 2 types. One is just a TRD kind of a thing in the periphery, fine. Another thing which I see is like, say, if you are operating at, say, 3rd or 4th week, many times they have an SRF, which might not have a visible regma. So in that case, you have one option is like treat it like a TRD, just put an oil. Second option is like if you're actually creating a break and draining it, the only option you're left with is doing a RR around the incarceration site. And sometimes that leads to a very bad prognosis at month 1 in some pediatric age group. So what should I be doing, like in an incarcerated retina with SRF? Just not plain incarcerated retina.
Usually we do the retinectomy around the incarcerated site.
That is the only option, right, sir?
So, but the most important is when the anti-segment surgeons suture the sclerocorneal wound, actually many times it is the retina along with that they suture actually. So that is a very big nightmare.
Yes, because like I did a retinectomy, I settled the RD. It was around 6/18 at around week 3 and week 4 as well. But it was a pediatric case and severe membrane proliferation at now week 8. So I was right in doing the retinectomy. I had no option. So I just wanted to confirm whether I made a mistake or no. Thank you.
So any other comments? So we'll go to our next topic. Dr. Aniruddha Maiti, he will present a series of cases with submacular hemorrhage.
Thank you, Shongita. I know everybody is hungry. I will try to finish as quickly as possible. Well, submacular hemorrhage, this is an uncommon complication, may arise from a CNVM, PCV or a RAM. The most common what we get in the OPD is a PCV bleed giving rise to a submacular hemorrhage. Why is it so important to deal with the submacular hemorrhage so early, as quickly as possible? Because the iron-induced toxicity is there. It can happen even less than 24 hours. And long run, it can be devastating. It can, there are a lot of studies which have showed that there is 6 lines loss also in the series where the 44% patient had 6-line loss. Diagnosis, what is important is we need to distinguish between the subretinal versus a sub-RP bleed. The color itself gives an idea. The subretinal is red and the sub-RP is darker. The OCT gives an idea. And obviously, if the bleeding is less, we can do the other investigation. Now, treatment, there is several treatments. It starts from the monotherapy of anti-VEGF, then the combination of the pneumatic displacement with anti-VEGF, with or without TPA. The TPA can be used intraretinal, subretinal, or intravitreal. So we will just go to the cases. This is the first case where there was a sudden dimness of vision. You can see the subretinal hemorrhage, but it was a thin hemorrhage. It has been said that if it is less than 400 microns, we can try with the anti-VEGF. So I did it, and with the second, with the one dose, you can see the hemorrhage has reduced, and after 3 loading doses, actually the vision improved to 660. So this is less invasive procedures. In the thin sheet of blood is there, you can actually try with the anti-VEGF monotherapy. Now case 2 is a submacular hemorrhage which was treated by the pneumatic displacement and anti-VEGF. This was a RAM bleeding. You can see the submacular hemorrhage due to RAM, and the vision was 3 feet. But after giving this pneumatic displacement in form of C3F8 and anti-VEGF, this patient has a breakthrough bleeding, which is a very known complication which happens after giving the injections. So this should be, the patient should be told about this complication which might happen. So then this patient was planned for vitrectomy. You can see still the gas is there, and it was a pretty dense hemorrhage. We'll just forward this video a little bit to save some time. You can see that very dense hemorrhage. Ultimately, we can see the little bit more. Yeah. So here you can see the bleeding has actually trickled down inferiorly. It was a superior bleeding, which is also a known complication which can happen. If there is a superior bleeding, it can come down. But luckily, the posterior pole was pretty good. And after doing the vitrectomy, this patient did pretty well. This is like after 2 months. You can see the hemorrhage is totally gone. We had done some laser around the RAM, and the vision from 3 feet actually improved to 612. Coming to the third case, this was a PCV bleeding, which is the commonest form of an submacular hemorrhage. You can see a large hemorrhage, and the OCT itself shows that this is a case of a PCV because the multiple PEDs are there. And this patient, we planned for a intravitreal RTPA, and this was 3 weeks after the RTPA. You can see the hemorrhage is considerably reduced. And this is like the vision improved to 624, and this is 2 months. The vision improved further to 6.9. Only there is a little bit of organized hemorrhage inferiorly, and after 3 months, actually, this vision, this patient regained the entire vision, that is 6.6. So the intravitreal TPA RTPA is a good option where it is a less, the intervention is less. And it has been, there is several studies. In fact, there is 38 studies which says that the studies with which has compared the intravitreal TPA with the subretinal TPA gives equally good results. This is the fourth case where the subretinal TPA was given with anti-VEGF and pneumatic displacement. This has some advantage when there is a subretinal pneumatic displacement is given. You need not have that positioning, and the intraocular pressure is not a concern. So this is, you can see a large hemorrhage. This was also in PCV. We'll just forward a little bit. Inducing in PVD. And with the 38 gauge needle, RTPA in the dose of 25 micrograms in 0.01 ml was given. I'll move to the position where we are giving the injection. Now this is where we are giving with a bubble of air is also given, doing an internal pneumatic displacement as well. Unfortunately, I don't have this patient, was an outstation patient, but the vision improved to 660. And coming to the last case, this was a relatively old submacular hemorrhage. You can see it has already been organized. Generally, it has been said that it should be done as quickly as possible. The patient said, let us give a try. So the same plan we had done, vitrectomy followed by subretinal TPA, anti-VEGF, and this was like a finger counting 1 feet. We can see the large hemorrhage and the central part is already organized. We'll just forward to the area where we are giving the TPA. Subretinal TPA has an advantage of dislodging the bleeding from the posterior pole, but at the same time, there is a chance that we might form a macular hole. That's a known complication. But this was a little bit atypical. This patient presented, I will just go to the next slide. This is what, after 3 weeks, we can see the hemorrhage has definitely reduced. The vision also slightly improved. After 6 weeks, even better. But after 3 months, the hemorrhage is totally gone, but there is a macular hole formation, and the vision dropped again. So we had to do the macular hole again. Obviously, a large macular hole was created. Maybe the force with while we are giving the subretinal TPA, it has induced a macular hole later on. We'll just skip it. Obviously, this was a large macular hole, so we had done an inverse peel technique. Luckily, the hole closed, and this is the picture after the macular hole surgery, and the vision improved to 660. Obviously, this was an old organized subretinal hemorrhage, didn't improve much. So these are the various types of, or rather 4 modalities of treatment for the submacular hemorrhage. What is important is after treating the submacular hemorrhage, we need to take care of the underlying pathology. In a macroaneurysm, we might need to do a laser. CNVM, we need to give anti-VEGF, because in a vitrectomized eye, the washout period is fast, so we might have to repeat an intravitreal injection. In a PCV, obviously now we don't have the PDT, but anti-VEGFs might be needed after the operation as well. Extrafoveal PCV, we can try and do a laser. So to conclude, as a general approach to submacular hemorrhage treatment, the pneumatic displacement can be combined with or without the RTPA, and if there is no contraindication, obviously. In addition, anti-VEGF should be administered as indicated to address the underlying pathology. Although some macular hemorrhage can be challenging to manage, reasonably good visual outcomes can be achieved in most of the cases. And out of the 5 cases we managed, actually, the first case had a little bit of scarring due to CNVM, so the vision didn't improve further from 660. And the organized hemorrhage didn't improve much beyond 660. But other than that, most of the cases actually does pretty well. Thank you.
Thank you, sir. I know everybody is hungry, but we can have 1 or 2 comments. Any comments from the chair, from the panel? Any comments from the audience?
Check. So what are your indications for submacular surgery? When do you go for submac surgeries in these cases?
Large hemorrhage covering the posterior pole, where conventionally, if there's a thin hemorrhage, we can put the anti-VEGF, but if there's a large hemorrhage entirely covering the posterior pole with a sudden dimness of vision, those are the cases. PCV bleeds and...
Yeah. What's the guideline you follow for subretinal RTPA or intravitreal RTPA?
No, as I showed, there was a ram bleeding. So the ram bleeding, and it was a little bit eccentric, covering the posterior pole. So where we have used only the pneumatic displacement and the anti-VEGF. In a case of a PCV bleed, to address the underlying pathology, we had given the anti-VEGF. But most of the cases, I do give this intravitreal RTPA. Wherever there is a large macular hemorrhage more than 4 disc diameter, or there is accompanying vitreous hemorrhage, then only I will give subretinal RTPA.
What's the idea of giving anti-VEGF in RAM lesion?
Sometimes this RAM also causes macular edema as well. Most of the cases we find it very elevated. Yeah, we could have done only pneumatic retinopexy as well, pneumatic displacement.
In lot of hemorrhage, even we have to do a TPA injection beforehand, and next day we do a vitrectomy and use PFCL, do retinotomy, take out the blood if there is a massive amount of bleeding in such cases.
It's always better to give, in any case, the TPA should be given first, wait for some time, and the gas should be given in a last. Nowadays, I have seen a lot of cases where with only this newer molecule brolizumab, it responds pretty well. Obviously, it should be thin. It should not be very thick. Like it's less than 400 microns can be managed with anti-VEGF only.
Depends upon the pathology.
Thank you.
Thank you, Aniruddha. We can consider Aniruddha as well as our guest speaker because he has directly come from airport to here and joined us. And I would like to thank all the delegates for spending the Sunday with us. And special thanks to all the panelists and our chairpersons and the moderator for moderating it so well. And I would like to thank our guest speaker, Dr. Naresh Babu. Thank you, sir. Thank you so much for enlightening us, and we all enjoyed your talk and your witness. And spending Dr. Rajiv was busy for his personal, but still he could manage to do it, and Dr. Ajit from Singapore. So we would like to thank all of them. Would like to thank Alchem, Alagan, and Intas for being our academic partner. Would like to thank Giri and Shogato as usual for taking the technical part of taking care of the technical part always, and neither less part by Apurbo, Shushantoda, and Shantanu. Thank you all, and join us for the lunch here.